Yes, also I congratulate to the winners, Dr. Digambar Bharne sir and Dr. Shavina Sheikh in ISA National Conference. So thank you very much. Long live ISA. Thank you.
Thank you, sir.
Thank you, sir. Vinal, please take it forward. We can hear you now.
Yeah. Now I welcome Dr. Soni sir, Dr. Sale sir is there, Dr. Deepa Kane madam is there. Sale sir, would you like to say few words? Sale sir?
Good evening to all Thane ISNs.
Yes, sir.
I think our secretary and the treasurer, president, I have not seen. They also joined. Good evening to all. And this year, Thane city branch is rocking Minal,
Yes,
and
sir.
the people are continuously arranging some programs and which are really worth attending. So I was almost missing. Actually, I am in one of the other meeting, but suddenly I remembered the message, and then I opened it, and oh, the 6:30. There is still time, so I started. Okay, all the best. Go ahead without wasting time.
Thank you, sir. Thank you
Salam
so
to,
much.
salam to
Your-
all Thanetes.
Thank you,
sir.
sir. Thank you so much. Yeah, Dr. Soni sir, are you there? Hello. Manisha?
No, I can't
Should
see
we-
him now. He was there. Yeah, we
Yeah.
will continue. Yeah.
Yeah, we will please start now.
Yeah, yeah.
It's 7.
Thank you, everybody, for your kind words and your blessings. Before we move forward, I just have a small announcement to make. As you know that on the request of Dr. Katkade sir, as we know that the Jito and Sri Mahavir Jain Hospital is organizing a marathon in Thane on the 20th of March, 5:30 in the morning. All the registration details I will be putting up on various WhatsApp group. I request all of you to register for this event and be a part of this noble cause run for cancer. We can make it a fit anesthetics campaign as well. I welcome all anesthesiologists from Kalyan, Dombivli, Navi Mumbai, Mumbai. You can wear your city branch t-shirts and we can all run for fitness and be a part of Maharashtra State ISA chapter's fit anesthetics campaign. So do register and do join us. Now we will move forward. It gives me great pleasure to invite our first speaker for the day, Dr. Tushar Choksi sir from Vadodara, Gujarat. The topic that he has chosen is Tiwa, Practical Approach and Updates. If you see sir's WhatsApp DP, it also says Tiwa, and that Tiwa means Tushar is a versatile anesthetist. And that is exactly what he is. With 30 years of experience under his belt, his specialty is in Tiwa, OFA, and NORA. He is the founder of the TIWA and OFA free Facebook groups in India and a national and international level speaker. He is very tech savvy and has started the smartphone and tele-anesthesia practice. He is very much famous as the infographics man and has almost all anesthesia related drugs and procedures in a one-page infographic slide format. This is widely used as a ready reckoner by many of us in our daily practice. Besides this, sir is a visual storyteller and a vlogger and a national origami teacher. I warmly welcome Dr. Tushar Choksi to start his talk on TIWA. Dr. Tushar Choksi, sir.
Thank you, Manisha. Can you hear me?
Yes, sir.
Okay. I'm very much delighted to see the ISA Thane activities, and I'm very thankful to all ISA Thane branch committee members and all Thane ISA. This is my 27th lecture in the same topic all over India and outside India. So this is very much near to my heart, this lecture. So now I will start my presentation. Can you see my presentation? Hello?
Yes, sir.
Okay. Now already my
Yes,
introduction is given by Manisha. So I'm moving to second slide.
Wait, sir, just a minute. You have started screen sharing, but we cannot see the slide as yet.
You cannot see the slides?
Sir,
No,
she
sir.
has started. It will take 2 minutes.
Now
we can see.
First slide we can see now. Yeah.
Okay.
You can start, sir. This is your introductory slide. Yeah, you can start.
Yeah. Just a minute. My second slide is not moving. Okay. Can you see my second slide?
No, sir.
No, sir. No, sir.
Not.
Now we can see.
Okay, so it takes time to
I think
interact.
a few seconds lag.
My second slide is seen, Tiwa practical approach
Yes,
and
sir.
then
Yes, sir.
okay.
Yes, sir. Yes.
I'll go to the third slide. Some network problem is there. Okay, now I will start. So today's my topic is Tiwa practical approach and updates, right? So I will ask everybody in the webinar, how many of you are giving Tiwa? What is your definition of Tiwa? What is your experience of Tiwa? Will you give Tiwa in your practice? Just to know you, I have started Tiwa practice long back, just 15 years back. And since last 15 years, I am doing only Tiwa practice. So my lecture outline will be history, definition, types of Tiwa, indications, advantages and disadvantages, Tiwa drugs and Tiwa combinations, method of giving Tiwa, syringe infusion pump, target control infusion. I have made my own infusion, Tushar Choksi infusion and closed loop system. Tiwa in different groups of patient, surgical procedures, Tiwa checklist and monitoring, Tiwa updates and Tiwa apps, what we are using, future of Tiwa, and summary and conclusion. Sorry, my slides are going fast. So if you see the history of Tiwa, Tiwa is older than inhalation agent. Tiwa started 350 years before, and first Tiwa practice done in Oxford, where the opium injection was given with alcohol in the dog. And since then, Tiwa has started tremendously, and the Tiwa changed the practice with the coming 1936 with the pentothal. And if you see the downline, the coming years, then ketamine started in 1962, propofol 1977, which has changed the whole practice of Tiwa. Then remifentanil, then dexamethasone, and lastly ramimezolam in 2020. So 1930, 50, 70, 19, and 2020 is the landmark years in the innovations of Tiwa practice. Now people are asking me, what is the definition of Tiwa? This is the real textbook definitions, and which includes, it is a technique of general anesthesia which uses combination of drug given exclusively by the intravenous route without the use of inhalation agent, including nitrous oxide, but oxygen, compressed air or helium are exception. So believe me, here nitrous oxide and other inhalation agents are not used, and Tiwa is used in induction as well as in maintenance of anesthesia. Here also there is a difference between all the anesthetists. Tiwa is not used only for induction. It is also used for the maintenance of anesthesia without any gases. Why Tiwa is becoming popular? Because gas gives always side effect in the form of aerosol and droplets. So Tiwa is better than inhalation agent. That is my view. What are the types of Tiwa? Here also you should know that types of Tiwa includes with endotracheal tubes, without endotracheal tubes. If it is without endotracheal tubes, then it is with supraglottic airway, without supraglottic airway. If it is without supraglottic airway, it may be with nasal airway or with oral airway. And Tiwa can be given without all these gazettes, which are considered as a airway gazettes. What are the Tiwa indications? First indications, almost in all surgical procedure, I am giving Tiwa, and it can be given in any situations like airway procedure and in PONV risk patients, post-operative nausea, vomiting, daycare surgery room anesthesia, anesthesia in non-operative locations. And if the patient is coming with the family history or positive history of malignant hyperthermia, then Tiwa is better. In remote locations, in neurosurgery, in neuromonitoring, now exclusively Tiwa has conquered over the inhalation agent, and even patient choice is Tiwa. And advantages, except for a slight prick in the arm, the patient is unaware of the having an anesthetics. The basic fundamental rule is you must have the IV line before starting total intravenous anesthesia. There is no mask over the face, no sudden concentration of gas or vapor, no risk of malignant hyperthermia, very low incidence of post-operative delirium, and less chances of emergence phenomena. patient's body is cooperating with this Tiwa, there should be no smell of volatile agents at all in the room, and the patient is usually most grateful for not having had his system saturated with this such a drug. One thing is, keep in mind, when you are using a inhalation agent, you must have a scavenging system. But in here, in Tiwa situation, scavenging systems are not required. It also gives advantage of better preservation of the cerebral autoregulation. It reduces the stress. Patient wakes up as it is from natural sleeps. In my 15 years of experience, I see that part. Now after dexmedetomidine, I'm very happy with the Tiwa practice. Less PONV. Almost there is no incidence in my practice of post-operative nausea and vomiting. Less operating pollution. So Tiwa is very useful in all the systems like central nervous system, immune system, cardiovascular system. Even it is given in post-operative pain relief for 24 hours. That I will come to later. It is very good for the older patient like geriatric, pediatric like that. It is very friendly in the renal system, liver system, gastrointestinal system, and oncology surgery. Almost all systems are very much favorable with the Tiwa. But there are some disadvantages. Coin has two sides. Pain on injections. Sometimes some drugs giving pain on the when we are giving intravenous propofol or sometimes intravenous etomidate. Injection is irreversible. Once you are given the injections of Tiwa agent, then it is irreversible. Disposable may be costly. TCI machines are very costly in this practice. Incidence of awareness if not given properly or if you are not monitoring well. Not having another apparatus to carry on the Tiwa. That I don't consider this is a major disadvantage because we have another choice of starting Tiwa practice. Possibility of not finding the vein, shallow respiration. Here, possibility of not finding the vein, that is inferior than inhalation agent because in inhalation agent, we can start without even IV line. Risk of bacterial contaminations. Cautions in prolonged procedures or obese patient. Sometimes people are asking how much hours you can give Tiwa. I had given maximum 7 to 8 hours for Tiwa continuously. And in ICU patient, when the patient is on ventilator, then the Tiwa drugs are given more than 24 to 48 hours. So Tiwa completes the anesthesia circle like hypnosis, sympatholysis, amnesia, hemodynamic stability, immobility, and neuromuscular blockade. What else you require with this any agent other than the inhalation agent? Which are the Tiwa drugs? All these Tiwa drugs are used for Tiwa, including benzodiazepine, narcotics, propofol, ketamine, etomidate, dexmedetomidine, muscle relaxants, and other agents are easily available in almost all the operation theater and outside OT that you have experienced. And the most better advantage and most beneficial is all these drugs can be given to any subset of the population from pediatric to geriatric in a titrable doses. This is my infographics of the drugs invented in last 175 years in anesthesia armamentarium. More than 65 drugs are invented. Out of these 45 drugs we are using, and out of these 25 drugs we are using as a Tiwa agent, except local anesthetic and some inhalation, all inhalation anesthetic. What is ideal Tiwa drug? Here you must consider in today's scenario, which is the which drug is coming near to ideal Tiwa drug. So it has a rapid onset of action, rapid and predictable recovery, potent and lipid soluble, water soluble, which minimize the toxicity associated with the solvent. It is stable in all solutions, whether it is a ringalactate or 5% dextrose or other drugs, chemically compatible with other drugs. No perivascular sloughing if extravasated, not absorbed by plastic, does not promote bacterial growth, and devoid of the adverse side effect. The most important, it can be mixed with the other IV anesthetic agent without any complications. Here also the Tiwa is better than IV this inhalation agent. We cannot combine two inhalation agent in the one vaporizer, or we cannot give two inhalation agents simultaneously. Here the Tiwa is far superior than inhalation agent because you can mix 2 drugs, 3 drugs, maximum even 4 drugs. So which are the Tiwa drugs toolbox? All benzodiazepine, then propofol, ketamine, dexmedetomidine, dexamethasone, magnesium sulfate, lidocaine, clonidine, diclofenac sodium, paracetamol, opioids. Each and every drugs are considered as the IV Tiwa Tool drugs box. And you will find in each OT all these drugs. So we will go to one by one in one slide with these IV anesthetic drugs. Propofol. Propofol is the prime Tiwa drug in any practice of Tiwa in all over world. It is given independently or in a combination with any Tiwa doses. Initially, Tiwa dose is 2 to 2.5 milligram per kilogram if I use adult. In Tiwa mixture, any mixtures we are giving 1 milligram per kilogram. And in maintenance infusion, it is given 6 milligram per kilogram per hour for maintenance. And co-administration of propofol and remifentanil is the ruling the world, because in all over world, the TCI machines which are available, target control infusion, these two drugs are very, very popular. This is my propofol infographics. I will share all the infographics with Thane City branch office bearers, and you will get it afterwards. So propofol has changed the Tiwa practice after pentothal in 1994. Second drug is in my weapon is ketamine. Ketamine I called as a Brahmastra for anesthesiologists in Tiwa. Without ketamine and without scoline, I never practice in my any anesthesia. Means I am not giving any anesthesia to any patients. It is the most popular drug for anesthesiologists across the globe since last 50 years. Believe me, one of the survey was done just 3 years back by one of the anesthetists group in the Facebook, which is the most popular drugs in the armamentarium, which is the most popular. So ketamine was ruling more than 55%. So it is a key role and main drug in Tiwa. Based analgesic, amnesic, and opioid sparing effect. Dose is less than 0.5 milligram per kilogram when you are using is a Tiwa practice. And when you are using alone, then it should be given with 1.5 to 2 milligram per kilogram. It is also as an anti-hyperalgesic and anti-tolerance effect. So it is the only intravenous anesthetic, hypnotic, analgesic, amnesic property. So this is the first drug which was invented with all the properties of the anesthesia. It produces hypnosis and profound analgesia. See, propofol does not have any analgesia. It gives hypnosis, but ketamine gives hypnosis and analgesia. So it is a very good agent. And the beauty part is it can be mixed with all types of anesthetic and narcotic agent in a single syringe. And this is most popular way by giving by the private practitioners. Ketamine with midazolam, ketamine with propofol, ketamine with dex, even ketamine with etomidate now. And one of the established drugs in the Tiwa mixture. One of the finest beauty of this drug is it can be given in the by any route in the body which is mentioned in the pharmacopoeia book. So it is the most popular drug. Second drug is dexamethasone. It is an alpha-2 agonist. Believe me, this drug, which are not used till now, so many anesthetists are very much frightened to use these drugs, but this drug is most ideal anesthetic agent in our weapon. It has got a hypnotic, sedative, and analgesic property and estimated to be 7 to 10 times more potent than clonidine, most ideal anesthetic agent. It has got even opioid sparing effect. Dexcat and ketodex combination is becoming very popular in pediatric Tiwa and OFA. Dr. Naresh Paliwal has introduced this Dexcat in his practice. Even I started, and now it is becoming very popular across the pediatric Tiwa. Here, patient is sedated but arousable. Like patient is sleeping, and when you are giving some stimulus, then he will immediately give the response. So it gives the conscious sedations post-operatively. This drug becoming widely popular in all parts of the world in all anesthesia practice. The dose range is 0.5 to 1 microgram per kilogram according to patient status and surgery needs. And I told you in pediatric Tiwa, it is most popular. So this is dexamethasone infographics. It is also given with all the route which is mentioned in pharmacology book. In animal anesthesia, the gel has came with the this dexamethasone. It is called silo gel. Now in human anesthesia practice also, this gel is coming by dexamethasone by the American company in near future. Those who are not using dexamethasone, I have developed one prayer for them. Hey buddies, I am dexamethasone. My pet name is Dex. I am your complete friend to play with you in all games, whether it is in IV, IM, oral, spinal, or nasal. But my favorite game is intravenous with all stages with sedation, hypnosis, analgesia, and anesthesia. I love to play with small babies to old age players. But during playing with me, be careful. I am very delicate and fall down with big players. I can also play in the indoor stadium in ICU patient continuously for 48 hours. I am always available to play with you and allowed me to play with others. Let us play and enjoy with me. Don't neglect me, though I am new player. So I request everybody to start giving dexamethasone. Another drug is etomidate. It is an excellent cardiostable drug. So I reserve these drugs for the non-cardiac surgery in cardiac patients, and I give for the induction as an induction, used mainly in hemodynamically compromised patient. For sedation, it is given 0.1 milligram. For Tiwa, it is 0.3 to 0.4 in ICU as a continuous infusion, and in geriatric patients, the dose is less, 0.2 milligram. This is etomidate infographics. Now we'll go to second set of the drugs like opiates. First is fentanyl. Fentanyl is very popular drug in India because remifentanil is not available now. Believe me, I have omitted using any narcotics in my practice now. So I am doing now exclusively opioid-free Tiwa. So I call this as Tiwa, opioid-free total intravenous anesthesia practice. I am not giving because my all drugs will give like narcotic effect. So fentanyl is given in 3 milligram per kilogram over 30 seconds is a bolus, followed by 2 microgram per kilogram per hour for 30 minutes, then 1.5 microgram per kilogram per hour for 31 to 150 minutes, and then 1 microgram per kilogram until 30 minutes before skin closure. Remifentanil is not available in India and I have never used it, but it is available as a 1 milligram vial, 2 milligram vial and 5 milligram vial. Initial dose is 1 microgram per kg. And Tiwa maintenance is 0.25 to 0.5 microgram. Some of the company in India is started developing this molecule, and in near future, 2 company will come in India with remifentanil, but the cost is very high. Cost will be very high. So this is fentanyl infographics. This is remifentanil infographics. The third drug is invented in 2020, just 1 year back, is a ramimezolam by Japanese company Payon. It is available all over the world now, except some Asian countries like Southeast Asian countries like India, Pakistan, Nepal, or something like that. See, it is a most popular drug now, most ideal drug. Believe me, when the propofol has changed the Tiwa practice in 1994, like that in 2022, this ramimezolam will change the practice of Tiwa because it is a combined property of benzodiazepine with opioid, and you will find everything in this molecule. Other adjuvant drugs are like midazolam, 0.05 milligram per kilogram. Co-administration of midazolam in Tiwa reduce the induction dose and total dose of any anesthetic drugs. And one of the caution is that total dose should be less than 10 milligram. I am not using now midazolam. So this is midazolam infographics. One of the most popular drug in my armamentarium is magnesium sulfate. Since last 4 years, I am using magnesium sulfate each and every patient. It is available as a 2 ml ampule with 500 milligram per ml and total volume. It has got an analgesic adjuvant useful in patient receiving total intravenous anesthesia. It reduces a propofol, dex, atracurium, and post-operative narcotic consumption. Bolus dose, I usually give 15 to 30 milligram, but you can give up to 50 milligram per kilogram with other anesthetic agent. Very cost effective, 10 rupees per ampule. Believe me, this magnesium sulfate I called as the intravenous oxygen for the anesthesiologist because it has got a 32 effect in the anesthesia when you give it. Like major effects are antihypertensive, bronchodilator, antiarrhythmic, analgesic, anti-seizure, anti-shivering, and anesthetic adjuvant, antacid, and mild sedative. What else you required in this molecule? This is my magnesium sulfate. This is the first infographics I started 2 years back with the magnesium sulfate. Another drug is dexamethasone. I usually give in 95 patients of my practice, 95% of the patients dexamethasone, except some short procedure. It is widely used in Tiwa as an adjuvant. It is an anti-inflammatory. It prevents and treats the post-operative nausea and vomiting. It is as comparable as to this ondansetron with the post-operative nausea vomiting. There are so many articles supporting this molecule. It provides a sense of well-being. In one single dose of 8 milligram, you will have so many good effect on your anesthesia time, good quality of recovery and early discharge in patient from Tiwa. And 8 milligram can be given irrespective of sex, disease or ASRS. And one of the things is that people are believing that 8 Dexona increase the sugar level in the body, but there are studies there that not more than 25 milligram at a time it will increase in some patient, but either it from 10 milligram to 25 milligram it increases the sugar level in diabetic patient. So it is dexamethasone, antiemetic, antinauseatic, anti-inflammatory, analgesic, anti-severing, increase the quality of recovery. No effect on sepsis and sugar in single dose. This is my infographics. I called as a universal friend. It can be used in the from pediatric to geriatric and any subset of the patient. This lidocaine. Lidocaine is also one of the prime drug in this Tiwa practice. It is analgesic, anti-hyperalgesic, anti-inflammatory, reduce opioid analgesic consumption, anti-arrhythmics, improvement in patient's outcome, and decrease the aerosol and droplet during extubation. This is intravenous lidocaine. Most beneficial in. I have developed one DML mixtures. DML mixtures means Dexona, magnesium sulfate, and lidocaine. I mix all these 3 drugs in a one single syringe of 10 ml. I take 1 milligram per kilogram body weight lidocaine, then 2 ml of magnesium sulfate, and 2 ml of Dexona. And over a period of 5 minutes, I am giving these drugs. Excellent effect. It reduces all the major anesthesia agents dose. There are some another adjuvants like paracetamol and diclofenac sodium. These 2 drugs I am routinely using in my all patients. Like paracetamol is a preemptive analgesic. It has got a opioid sparing effect. Loading dose is mostly 30 microgram per kilogram and should not maximum should not exceed 2 gram. Very innocent drugs in Tiwa and can be repeated at interval of 6 to 12 hours in a dose of 100 milligram. For 2 days post-operatively, I give all my patients 1 gram of 100 ml pint to all my patients post-operatively. It is an excellent adjuvant in pediatric Tiwa also. Diclofenac sodium is also powerful analgesics. It's in Tiwa and it has got an anti-inflammatory action. Best is given in a single dose of 1.5 milligram. Here I want to say that people are asking me why should give 1.5 milligram. The dose is not 1 milligram per kilogram. It should be 1.5 milligram per kilogram. Slowly, maximum is up to 150 milligram. If you want a complete effect of diclofenac sodium on these prostaglandin inhibitors, then it should give it a 1.5 milligram. Now, aqueous solutions are available, but we have to be careful in renal, hepatic, pulmonary heart patients. The thumb rule is that in any Tiwa practice, these 2 drugs should be given before the skin incision, because once the skin incision is there and the receptors are released, then there is no effect, means not that effect which gives before that skin incision. And this is paracetamol infographics. This is diclofenac infographics. One of the other drugs which I am using regularly is Esmolol. It has got a opioid sparing effect and gives central anesthesia. In my all laparoscopic patients in Tiwa, I usually give Esmolol drip, and I call it as an emergency friend of anesthesiology. So many anesthesiologists are experienced that there are sudden hypertension, means blood pressure increasing during the CO2 insufflation, or in some patients of laparoscopic anesthesia. At that time, this Esmolol gives a very good effect. It is a very short acting, so it is a very selective. It gives a significantly decrease the anesthetic analgesic requirement. It has got a central analgesia. So it is a Esmolol infographics. Now come to the Tiwa drug combinations. But you should understand before mixing any drugs for anesthesia. People are always asking, why are you mixing the drugs? But there are scientific reports in pharmacology books, and I will give the support of this. The concept of anesthesia triangle works with the hypnosis, analgesia, relaxation, and their interaction, what we have learned in our anesthesia residency program. Any drugs enters in this prism, they will get absorbed with the anesthesia triangle. So some drugs are acting as a hypnosis, some drugs are acting as a relaxation, and some drugs are acting as an analgesia. So the rule is not mix more than 3 drugs at a time. And these, according to this, Any medication entering this prism may result in different interaction like pharmaceutical, pharmacokinetics, pharmacodynamics, and thermodynamics by combo. A large number of incoming drugs leads to increased complexity and more interaction. There is one article in Columbian Journal of Anesthesia, which was released 4 years back, and there were conclusion where drug interaction are the cornerstone of the anesthesia triangle, and being aware of those interaction may contribute to safe anesthesia. These green squares are compatible with all these drugs are written here and on the upstairs, and some of the red drugs are like propofol cannot be mixed with some of the C-cetacurium, or ketamine can be mixed with any IV agent. So like that. I have developed one Tiwa kingdom. Those who can't understand the Tiwa practice, we are the anesthesiologist. We are the prime king. Prince is the propofol. Ketamine and Dex are the first and second supreme commander. Fentanyl and remifentanil is a commander. And others like lidocaine is a magic soldier. Esmolol is a emergency soldier. Then diclofenac and paracetamol are a best soldiers, and magnesium sulfate are oxygen soldiers, and others are a. So here, what happens? Here, king will decide. We will decide in our battle that what anesthesia drugs we will combine in our military, and Tiwa whom to send alone or in combination. Either we will give only propofol, or propofol with Dex, or propofol with ketamine. So we will decide. Prince is the most common warrior and goes in the every battle of Tiwa anesthesia. Without propofol, Tiwa is nothing. So Prince is always going with this battle. In Tiwa maintenance also, Prince with one or two supreme commander. Like this Prince propofol is always with the maintenance to induction to maintenance, and ketamine or Dex can be added. They are the best military king. And in pediatric Tiwa, in absence or presence of Prince, two supreme commander go to win small battles like Dexket, like ketamine and Dex. These two Dexkets are very much popular in. Hello, somebody is speaking in. So these are the combination. Can you move this fellow? So these are the combinations which are across India and across globe we are using. All are established mixtures in Tiwa practice. One is KPD mixtures, that is ketamine, propofol, and dexmedetomidine. This ketamine mixtures probably in India I have developed first time in just 6 years back, and I had given more than 10,000 patients in my gastroenterology practice. Second is ketofol. Ketofol is a much popular with all the anesthetists till now, and today also ketofol is most 98% to 99%. This combination is very much in Tiwa. Third is Dexket, ketamine, dexmedetomidine. People have used fentanyl with propofol or remifentanil with propofol. Even in South India, some of the anesthetists are using propofol, dexmedetomidine, fentanyl, midazolam, or ketamine like PDF, MDF, or Ketomed. So ketofol is first established Tiwa combinations. Physically compatible, chemically stable in 1 gem 1 mixtures. No significant change in pH up to 3 hours. No separation, crackling, color changes, gas information, and it is widely used by all the anesthetists like Ketodex and Dexket, Ketomed. Here you should remember only rule of 1. Either it will be 1 milligram or 1 microgram or 0.1 microgram. The dose is like that. And this is the mixtures I have developed in 1 gem, 1 dose, like ketamine 1 milligram, propofol 1 milligram, and Dex 1 microgram in a single syringe. Combination of all these drugs permits lower dose of each individual agent for Tiwa and reducing their adverse hemodynamic and respiratory effects. I use as a bolus maintenance and short case less than 30 minutes. Advantage is low dose of each agent compared to full dose. Here ketamine gives analgesia and light hypnosis. Propofol gives full hypnosis, and this dexmedetomidine gives both the way. So it is excellent analgesia and anesthesia. It reduces the dose of individual. It decreases the airway complications. It's stable hemodynamics and rapid recovery. In my all laparoscopics and major surgery for 6 hours in Tiwa, I'm using these combinations. The most popular another combination is propofol and fentanyl. It is given in the combination of propofol 1% or 2% with fentanyl 10 to 50 microgram per ml. Propofol dose reduced by the 50% by fentanyl. And this is RP-TIWA, that is remifentanil and propofol. It is the most widely used TIWA combination with TCI in the world. In Western countries, everybody is using this combination in TIWA practice, almost everybody. It can be mixed with the polypropylene syringe and used for up to 36 hours. Remifentanil concentration is 50 microgram per ml. Color and clarity good with pH stable at 3.9 to 4. Ultimately, two drugs are going simultaneously in the body, so they mix in the body only. Very short acting, adequate analgesia, satisfactory hemodynamic, rapid recovery, shorter PSU, and excellent patients. See, all the anesthetics, even in Thane or Vadodara or any part of the India, they are not used to with the TCI machines. Hardly 3 to 4% in my survey, they are using TCI models in their TIWA practice. So most of the practical, what I am giving you practical updates, I am using this as an infusion or in single syringe or with the some of the another method. Here the propofol dose reduction is 50%. Now, what are the methods of giving TIWA? Either with a single drug or with a combination of drugs, either with single syringe technique or mixture of the drugs with only one drug. Continuous IV infusion, with infusion pump, with target control infusion, and lastly automated drug delivery through. You just sit in chair and the drug will be controlled by the some of the TIWA machines and computer. Closed loop anesthesia. So you'll go, this is my most favorite single syringe TIWA. No additional investment, simple syringe or pump can be used. Only one syringe is used with the advantage of dose titration. Short procedure can be managed with intermittent, and even it can be practiced with the NORA situations outside operating theater. Manually control infusion, MCI, manual dosing of anesthetic agents during TIWA with fixed infusion rate with syringe or without IV drips, or with syringe or with IV drips. And these are the total intravenous anesthesia sets are available even in India also. You can use it. Now come to the main in TIWA, target control infusion, TCI. A target control infusion in an infusion control to achieve preset drug concentration in the plasma or the effect site. See, some people, some anesthetists can't understand the TCI models and always they are not using that because it is complicated for them. But here you must remember key components of these are user interface to enter details and target bulk concentration, software with the pharmacokinetics model, and communication between control unit and pump hardware. Once you will start TCI machine in your practice by setting all these parameters, then it will be very easy. But you have only two drugs available for that, either propofol or remifentanil. So these are the single syringe TCI machine available, double syringe, 3 syringe. Now China people came with the 5 syringes and 10 TCI syringes. I consider he is a father of modern TIWA practice who has invented deprefuser pump in 1996, John Bayard Lane from England. So clinical benefits are more predictable onset in TCI TIWA, more predictable offset, short time to recovery, because propofol and remifentanil both are very short acting, low incidence of PONV. Economic benefits are save nursing time, limits the need for antiemetic therapy, allows patient an early return of the work. And these are the models are available like Mars, Cinder, Perfuser, Kataria, Minto for each specific agent. Now I develop my own infusion like Tushar Choksi infusion as a maintenance of infusion during TIWA. 3 styles. I am giving either with patient's status and considering the duration of the surgery and with the age, gender and sex. Means KPD infusion. That is ketamine, propofol, dexamethasone. In induction, I give 1 milligram, 1 milligram, 1 milligram. But in infusion, where for maintenance, I give 0.5, 0.5, 0.5 per kilogram per hour in 500 ml diluted. If I am using dexamethasone infusion, then I give 0.7 to 1 microgram per kilogram per hour. If I am having a pediatric patient, then I have to go little bit more doses. Propofol infusion 6 milligram per kilogram per hour, and I dilute only 100 ml normal saline. And this is without TCI machine. Now coming to closed loop anesthesia, it is called a auto anesthesia, means automated total intravenous anesthesia. ATIWA or CLADS, a closed loop system, the ideal means of automated. Here two things, input is drug delivery, either propofol or any opiates or any other agent. Output is monitors, which we evoke potential, then blood pressure, pulse rate, even process EEG machine. So here, if you consider that computer is in between, outputs are monitor, inputs are drug delivery. The drugs are going inside the body. According to drugs, the computer will decide by these monitors which dose is to be repeated. So it is an automatic closed loop system. And these are the machines are available for closed loop models. And it is one of the PGI Chandigarh, Dr. Puri has invented this type of the machines, and we are very thankful for him and we are very proud of him. It is automatic delivery of the anesthetic drug, frees the anesthetics from the repetitive task. You just sit in the chair and just see that everything will be controlled by this auto loop. Anesthetic is one if there is an abnormal rate of drug. If you set the blood pressure, even heart rate, then also it will be measured by this this closed loop system. Now in the world, another way of Tiwa is coming, like I control RP or I control RPR. That is, I control RP is a remifentanil propofol combination and remifentanil propofol retraction. It is a auto robotic Tiwa clades. US FDA approved, and in Canada it was developed by a team of one pediatric anesthesiologist. So even here we are not coming in the picture for giving Tiwa. Even computer, that is an artificial intelligence anesthesia practice. Now there are some of the different groups of the patient how we are giving this Tiwa: pediatric, geriatric, obese, and risk 3 patients. In pediatric practice, as far as I would in Tiwa in neonates, pediatric total anesthesia reduce the airway responsive, minimize the complications such as post-operative nausea, vomiting, and emergence agitation. Here, sometimes inhalation agents rule over the Tiwa practice, because once you put mask over the face, then patient goes in, then you can take the vein and you can start this Tiwa practice. But for the Tiwa practice, you must have the IV line. Dexcat or Ketodex is very much popular. I have told you in Tiwa, in pediatric Tiwa. Tiwa in geriatric practice also very much popular. Compared with inhalation anesthesia, Tiwa is more suitable. Here the rule is go low, go slow, and always follow. Means whatever the drugs you are giving, always given a less dose. Go with the even double the arm brain circulation. When you are giving propofol in a normal anesthesia, normal risk patient, suppose if you are giving propofol in a 2 minutes of total dose, then here you start with the 4 minutes, at least 4 minutes. If you give slowly, then the effect is very good. And always follow this rule. The most important part is to avoid hypertension. Consider intravenous fluids and vasopressors whenever appropriate when you are practicing Tiwa in this type of the patients. Multipara monitor and oxygen is must during this Tiwa in geriatric practice. Like in obese patient also excellent method, but the rule is that you must secure the airway. And recommended dose is obese patient is always lower than the non-obese patient. When you are intubating this patient, then some people are practicing no relaxation technique, but it is not advisable. Always use suxamethonium or other depolarizing or non-depolarizing muscle relaxants for intubation. In obese patient, always secure airway. Here also multipara monitoring and oxygen is must. Even Tiwa in ASA 3 patient or 4 patient is this popular. Tiwa can be given to seriously ill patients. I am giving sometimes in even ICU patient for some procedures in ICU also. So at that time, Tiwa is very beneficial in my practice. There are no specific protocol, but Tiwa in dose of Tiwa of elderly patient can be adopted. Choose of the drug in Tiwa, it is whether the patient is elderly or young, or whether the patient is obese or non-obese. You must select. Here also multipara monitoring oxygen is must. So considering all this, my dialogues, surgical procedures done under Tiwa is from OT to outside OT, from pediatric to geriatric, and from any surgical to medical specialty. What else you required? Some of the Tiwa checklist, when you are giving some Tiwa practice, you must consider all anesthesia drugs, airway equipments, oxygen, multipara monitors are before giving a Tiwa. Ensure no leakage from cannula. You must secure IV cannula. during the surgery. Syringe should be labeled. This is a prime importance with drug name, date, and concentration. Hello. Infusion line should be checked every 15 minutes during surgery. The infusion set through which Tiwa is delivered should be have lever lock system. If BC is used, this is fundamental in monitoring. But all anesthetics are not facilitated by this BC monitoring. So check placement before and after surgical draping, BC electrodes, and at the end ensure all tubing IV cannula with which had Tiwa drugs by any method are flushed to prevent inadvertent bolus in the ward. What are the monitors we are using? I consider myself as the best monitor till now because I learned in my residency program that we are the best monitor whether any monitor comes in the anesthesia practice. But I will be, even I in my practice also, I can see that SpO2 is going down, then also I can predict that SpO2 will go down and everybody will be experienced. So anesthesiologist is the best monitor for the Tiwa practice. Here you should see loss of response for shaking or shouting, loss of hemodynamic response, absence of tachycardia or even bradycardia. And some machines like multipara monitoring, bispectral index, evoke potentials, process EEG monitor, they are used as a Tiwa monitors. So Tiwa has become more popular, practical, and possible due to two main reasons. First, the advanced knowledge of the pharmacokinetics and pharmacodynamics properties of drugs such as propofol, ketamine, dexamethasone, and newer short-acting opioids, making them suitable for IV administration. And second, new concept in the pharmacokinetics modeling coupled with the advance in the technology of infusion pumps, which allow the use of algorithms such as syringe infusion pumps, target control infusion, closed loop system. In 2022, you will be having even dexmedetomidine TCI pump in your practice. And propofol with fentanyl seems to be dominating the Tiwa practice all over the world. Some of the Tiwa apps are available in the Android and Apple. That is iTiwa. Do Tiwa with your smartphone and volumetric pumps. I am very much savvy with the smartphone, and I always take advantage of my smartphone with Tiwa practice. Second is IV calculator for infusion dosage drugs and drip rate, then infusion calculator, then anesthesia software, calculation of plasma concentration of PK/PD models. And this is the total Tiwa dedicated textbooks are available in the Amazon and free soft copy. If you want, then I will give you in this Thane Anesthesia forum. So it is editor is Epsilon, and he is the masters in Tiwa practice now. He is doing only Tiwa practice since last 35 years. So Tiwa, in fact, patient friendly, surgeon friendly, anesthesiologist friendly, economically friendly, environmentally friendly, productivity friendly. This is how it is used. Tiwa will be norm in future practice. In future, auto Tiwa through artificial intelligence with the help of TCI and BIS, and coming time in 2030, even metaverse anesthesia with Tiwa, it will come in the practice. Dexmedetomidine TCI model Herniwood and Dick will be launched in 2022. Like vaporizer, my dream is the syringe pumps and TCI machine will be integrated into the Tiwa anesthesia workstation. So whenever the vaporizers are mounted in the workstation, I must say that now TCI pumps should be mounted in this our trolley. Tiwa will be norm and new normal. Tiwa will rule in all anesthesia techniques by 2030. And people have developed all in one TCI and CLA. One machine is for TCI and one is for CLA, like Swedish jackknife. Even some TCI pumps, they are developed with the, even you can play with that. You have a screens and you can play with the joysticks. And this is which we are using now. Everybody is using like this complex theater, machines, monitors, and everything. But my dream is that future Tiwa anesthetic workstation is having only one button, that is in one mode, that is asleep or awake. When you want patient in the asleep mode, then you just put patients with all these height, weight, sex, dose, time of durations of anesthesia, surgical procedures, and you put on the sleep mode in the patient. And whenever you want to awake the patient, then put on the. And in between, if you want a coffee, then you can take from the anesthesia machinery. EI monitors will be also in that part. So this will be a switch on, switch off anesthesia machine. Newer drugs came in the Tiwa, like I told you, Remimazolam, combination of narcotic benzodiazepine in 2020. Sugamdexin came in 2015. It's a reversal agent, but believe me, it is a very costly drug. It is 28,000 rupees per ampule. So it is far from our dream even. Heptiva and Duzitol, these two drugs are coming in the market like anesthetics plus narcotics, combines the pharmacodynamics of propofol with pharmacokinetics of remifentanil. Duzitol, anesthetic plus narcotics plus muscle relaxation, combines hypnosis, amnesia, analgesia, muscle relaxation, and aphrodisiac. So my take-home message is total intravenous anesthesia is viable and safe alternative to the inhalation anesthesia. I am not against with the inhalation agent, but my choice first is Tiwa with lots of advantages over the better. TCI pumps and advanced monitor make administration of Tiwa easy and precise. Manual control infusion using regular syringe pump can be used to deliver pre-calculated dose instead of TCI machines. And newer intravenous hypnotics and analgesic agents with favorable pharmacokinetics properties have made Tiwa more popular in a wide era. So think outside of the box. Those who are not using Tiwa, you continue your IV inhalation practice, but in some percentage of the practice, you go for the Tiwa. Step in your comfort zone with the Tiwa for safe anesthesia, safe surgery, safe patients, and safe yourself. So what patient needs? Don't think. Start practice of Tiwa. And today, what is your opinion of using Tiwa in your practice? You will say, I won't use Tiwa, I can't use Tiwa, I want to use Tiwa. How do I use Tiwa? I will try to use Tiwa, I can use Tiwa, I will use Tiwa. Yes, I have used Tiwa. So all questions answer is there. And you just ask yourself which way you want to. I have developed a one Tiwa Facebook group. In that 6,000 members are there from 189 countries, and you will find all the materials in this Facebook. Please join with this society. And there are the different Tiwa societies are developed, EuroSiva, World Siva, and Siva.USA. You will find all the articles of Tiwa related in this. Thank you. And believe me, we are doing one workshop in GARC, means that is a Ganga Anesthesia Refresher course in next month, means in May from 6 to 8. This is the first type of hand-on workshop on Tiwa practice in Ganga Hospital, Coimbatore. Please, if you have patience for Tiwa, then come and join with our Tiwa workshop. Thank you.
Thank you, Dr. Tushar, sir.
I have crossed the limit, but
No.
probably
that is okay, sir, because it was one of the most clear, most complete, and most comprehensive lecture that we have heard in a very, very long time. And actually, we can go on and on. I'm sure a lot of us will now start practicing Tiwa. At least, if not all the drugs, one by one, we can start adding one new drug in our kitty and make Tiwa a very pleasant experience, not only for the patient, but also for us and for the staff. Thank you very, very much for joining us.
People are using Tiwa practice,
yes,
but they want to, some people are not using dexmedetomidine, so that is why I am very passionate to give this lecture in all the parts of the world and in India also.
Yes, dexmedetomidine, I think people are starting to use, but some people are still scared of using magnesium sulfate, because for us, magnesium sulfate is only related to eclampsia. And you know, so getting that barrier out of our heads and making that magnesium is a very good drug for anesthesia.
I have used more than 10,000 ampule, and people are giving. The only thing you have to remember, whenever you give magnesium, you should tell the patient that you will get a warmth in the body when you start giving. Even Dexamethasone also gives the warmth in the body. So that is the only requirement. And believe me, the magnesium sulfate and Dexamethasone is excellent for Tiwa. Even in inhalation agent, I'm telling you, everybody is using now.
Thank you very much, sir. Thank you very
much. Any questions?
Yeah.
I am open to tell.
There aren't too many questions in the chat box.
Manisha, there is one question.
Nilima, just a minute. Yeah, there is only one question, who has asked the dose of Esmolol in the drip, right?
Yeah.
I am giving Esmolol. See, I mix it in the 100 ml pint, 10 ml of bulb, and I used to give at least 16 to 18 drops pre-operatively. I start pre-operatively, And I put bolus dose also with me because it is a very short acting drug. So once the blood pressure goes more than 140/80, hello, can you hear me?
Yes, sir, we can
Yeah,
hear you.
if it goes more than 140/80, even my surgeon, she is not allowing in going below 120 also, because he does not, or she does not want going even hypotensive technique, because he wants normal blood pressure in my laparoscopic procedure. But sometimes when with the lapro lift up with the carbon dioxide insufflation, the blood pressure goes shoot ups like 210/140 sometimes. At that time, if you give bolus dose of even 6 to 7 ml, up to 6 to 7 ml, I am telling you, then it will be good for the immediate control of the blood pressure. And for during that time, during infusions, I told you in 100 ml of NS, I am using 10 ml of bulb, putting all this and 15 to 16 drops. It is a very short acting. So once you give, it will be out of the body within 2 minutes.
Thank you, sir. That was very helpful. And you have been also very generous in sharing your PDF and the
This
book
is my
also.
only practical experience. I'm not a textbook savvy, or this is myself and Dr. Naresh Paliwal. I must say that Dr. Naresh Paliwal, I salute him. He's my senior friend, and believe me, he started a segmental anesthesia, spinal anesthesia, and Dexamethasone. Everybody is now passionate about this. We are conducting one workshop in our Gujarat on after 3 days, and
Yes.
he's coming for that.
Yes.
So every time book, picture, or journals, articles they are not up to the mark. Even private practitioners are also one of the academicians, and this is in my life, which I have proved in our society.
Thank you very much, sir. Dr.
Thank you.
Paliwal, sir, is also in the audience. Dr. Paliwal, would you
he is
like
there.
to make any comment, please?
That was very nice of you, Dr. Tushar. I always contact Dr. Tushar Bhai for any queries regarding Tiwa.
Yeah. We are very good friends.
And actually, I am very much, very anxious about the forthcoming workshop, because this is the first of its kind. So I am a little apprehensive.
The beauty
about
part
the
is that we
workshop.
never
I'll
met
be-
each other.
I'll
We
be
never
going
met each
there
other.
tomorrow. Yeah, we never met each other. And this is a first of its kind workshop on segmental
Yeah,
spinal.
first kind of
on
workshop
Sunday.
in all over India.
Yeah. There are more than 125 registrations already there.
125 people are on it.
So,
Very nice in
I am
small town
little-
of Gujarat.
Now, sir.
Yes.
Thank
Thank
you.
you very much for the kind introduction, Dr.
Manisha, my suggestion is you also do workshop with this segmental spinal in Thane also.
Yes, sir. Yes, sir. Definitely. That is definitely in the plan, in the pipeline.
Yeah.
Thank you very much. We have
Thank
to
you.
move forward now to the next speaker, and I request Dr. Nilima Kelkar, our scientific secretary, to take over and introduce the next speaker. Dr. Nilima.
Yeah. Hello, everybody. Our next topic is very interesting and very pertinent. It is about ergonomics in anesthesia. I invite Dr. Anjali Puntambekar, senior physiotherapist, to guide us about it. Dr. Anjali has done her physiotherapy from GS Medical College, Parel, and LTMMC Siam. She has done PG DEMA from Indira Gandhi Open University. She has special experience in management of hand conditions, rheumatology, MSK cases, and pediatric neuro cases. She is PG guide and has many publications in national and international journals. At present, she is working as professor and HOD of MSK department in SIA College of Health Sciences, College of Physiotherapy, Dombivli. Welcome, Dr. Anjali. You can proceed now, Dr. Anjali.
Thanks, Nilima. I think it's a very different feeling when you are introducing me professionally. Anyway, I'll start sharing the slide. Is my first slide visible?
Yes.
At the outset of this webinar, I would like to thank the ISA team for making me a part of this program today. And it was really nice to get glimpses of this Thane family doing such a great work. professionally, as well as your contributions to singing and playing music. I think that was a wonderful thing to know. Today I'm going to speak about balanced posture, and I'm really grateful that you answered the link we had sent to you. We were in a process of giving you some exercises that you could do during your work also. So balanced posture is very important for all of us so that we stay away from aches and pains. And when we are standing, sitting or lying down, we are in a state of static postures. But as we start walking, moving and even driving, we have to have more of neurodynamic control. So we need to have a good structural integration with the active elements, that is the muscles, the passive support from our ligaments, and the osseous support that we have from our bones. Sometimes fear or certain psychological aspects cause imbalance. And with imbalance, we lead in pain and our work is disturbed. The main causative factors of these postural imbalances, even after doing exercises, are we are not cognitively doing our exercises. And most of you, when you are doing your monitoring, you are in a flexed posture. Such flexed postures for long times are causing weakness in your core muscles, that is your neck flexors, and tightness in your guy wire muscles, that is your pectorals. Same thing happens even in your lower limb, wherein your hamstrings and gluteus maximus and core muscles which are going weak. So whenever such problems come to us, first thing that we do is a assessment. We look for your dyskinesis in your scapular muscles as well as pelvic girdle. So first and foremost, we have to mind our postures and we have to be aware that we are making some mistakes and we need to correct them. Whether we are in standing position, sitting position, sleeping position, or even during exercises. So whenever we are standing with more weight on one side, that is what is giving firing at our ankle joint, knee joint, SI joint. It affects our lumbar spine, thoracic spine, and puts in pressure on our scapular muscles as well as our neck. So the best guide to assess your posture would be standing against the wall. So if you just stand against between your occiput to the wall, you could measure the distance between your tragus and the wall. See if your shoulders can get retracted and you can touch the wall. Same thing with your glutes muscle and your knees and ankle. Even when you're sitting, if you go into relaxed sitting, you go in more of flexion posture where you are affecting your neck, your pectorals, same way with your hip flexors, knee flexors, and even your foot muscles. If we just mind ourselves and get little bit more erect, I think we are using our extensors. Most of the time we go and acquire these flexion postures, and this is how we start getting pains. More pressure is coming on our upper fibers of trapezius, levator scapulae, and it affects the activity of rhomboids, middle fibers of trapezius, and lower fibers of trapezius. So all our exercises are going to be targeted to achieve activation of these muscles, which would otherwise go weak. Same thing in case of your driving. Too much of flexion is going to overload your muscles and cause weaknesses and tightnesses. Again, your sleeping postures are also very important. You need a pillow to support your cervical curvature. Too much of full pillow is going to put excessive pressure, and no pillow is going to imbalance your muscles. So what is the solution for this? We need awareness of our body. How are we moving our bodies while at work or even during relaxation? Make corrections, maintain the length tension ratio. As per the ACSM guidelines or WHO guidelines, I think everybody has to put in 150 minutes of exercise per week, wherein you have to follow a basic protocol. You start your exercises with a nice warm-up, go for stretching exercises, go for strengthening exercises once your body is ready, go for a cool down and then stop. Again, your footwear, especially when you are standing for very long time in the OT, you need to have a supportive and a firm footwear. Even when you are going for long walks, jogging and jumping, because such kind of good footwear is going to give support to your entire lower limb kinematic chain, and that is going to support your spine also. So whatever ground reaction forces are there, they are going to be transmitted in a anatomical way. So this is a basic exercise which I think all of you could do, and I think all the OTs have walls. So a basic chin tuck exercise to correct your neck posture, and especially after you have monitored your case for a long time and you activate your core muscles in the neck, and you are much better. Otherwise, I think your small aches and pains start with little trigger points. And if you don't take care of those trigger points, they go into tight bands, and finally you lead to wrong postures. These are another favorite part of our exercises where we are targeting the scapular muscles, especially your rhomboids, middle and lower fibers of trapezius, and serratus anterior. So if your scapular muscles are aligned well, they how you take away the excessive pressure which is coming on the upper fibers of trapezius and levator scapulae. Once you are in an erect posture, your tightness of the pectorals is also taken away, and it tall and look tall. Same thing you can do for with your lower limb muscles also. You can activate your hip flexors, gluteus maximus, hip abductors. Such simple circling or movements are going to activate these muscles and take away all the fatigue which is setting in due to prolonged standing. So keep moving. Another problem that I have seen in many of your cases is overloading of your wrist muscles. Even lot of you have pains on the ulnar aspect of your hand, and TFCC affection is also commonly seen among you. So good stretching and simple smiley ball or putty exercises do help to strengthen your hand muscles. But if you have a good proximal stability with whatever exercises I mentioned earlier and your scapular stability, your hand muscles will work and be much more happier. These are some exercises wherein I've shown you a little bit about stretching, and this is the new concept which we work on, is the myofascial release. So before we go even for actually stretching of your long muscles, we start releasing your fascia first. So these are the foam rollers which are available, and they are helpful in a great extent to release the fascia of your cervical spine, thoracic spine, lumbar spine. They can be used even remotely when you are releasing your plantar fascia muscles. If you don't want to use a foam roller, even a small tennis ball would do, and it works wonders as a good exercise aid. Then you could start with your TheraBand exercise, stretching exercises with TheraBands, which is going to give you good amount of muscle lengthening And these resisted bands, as you change the color of the TheraBands, they give you good exercise strength also. So it's like a small gym which can be carried anywhere and everywhere, even in your small bag. From stable surfaces, we can move to unstable surfaces to challenge our muscles further, which helps to improve our balance as well as coordination. So vestibular balls and your stability trainers, they come for a help. Even walking, tandem standing, walking on a small line, in a straight line also helps to develop your coordination to a great extent. You know, when you keep on changing your exercises, it breaks the monotony of your exercise and it motivates you to continue for a long time. Even lot of Bosu ball exercises we are using as unstable surfaces. Many of you would like to go for aerobics or Zumba, but be careful. If you are very tired, maybe you land into injuries with such kind of vigorous movements. Comparatively, if we use aquatherapy, I think it's really relaxing. And there are a lot of resisted exercises which are offered with all these kind of tubings and weights. And they have special relaxation techniques also. So I think all your stress also is managed with techniques like shiatsu. Cycling is another great exercise, especially exercising outdoors. Another major thing that pillars to a good posture, good ergonomics is a nice full sleep, eating healthy, as all of you know, and maybe some bits of small nuts or lemon juice in between, some time to relax and meditate. I think all of you have heard about the term mindfulness. Now for clinicians, we have come with another useful term, that is heartfulness. So whatever 4 pillars I just mentioned, they can be combined together into this heartfulness. These are the office stretches which we like to share with all of you, because most of your meetings and learning is occurring online these days. So whenever we are sitting on for long time and listening to all our Zoom meetings and going for our learning methods, I think we need all this and it should be pinned up in our offices and we should follow it. So here I'm going to show you some exercises. If you want to do it as you see the videos, that is also possible, because we have made it really simple. First and my favorite exercise is a chin tuck. You can see he is putting his finger on the chin and pressing his chin behind. Maybe from the front view it is not visible, it is quite visible from the side view. So he just activated his neck muscles. Now let's see how he goes for shoulder retraction. So pressing your shoulders behind and holding it for some time to activate your rhomboids and middle fibers of trapezius. I think all of us can do this even when we are sitting with a chair support behind. Let's move on to the next exercise set. As I had showed you all the T, Y, and W exercises, you could put your hands together, elbow and shoulders in the same line, and press your hands behind so that the elbow touches the wall. See, here again, you are activating your rhomboids, middle fibers of trapezius, and lower fibers of trapezius. Now here you would see a little variation wherein your lower fibers of trapezius and serratus anterior is also activated, because as he is pulling down the scapula, it activates those muscles also. It will be visible from the side view. This is a Y exercise. So we have targeted almost all the muscles around the scapular region to maintain a good posture there. One more exercise, very important, is diaphragmatic breathing exercise. Let's see. I think all of you can appreciate as he is breathing is in, his tummy is coming out, and as he is breathing out with the O of his mouth, his tummy is moving inside. Why we used wall for support? This gives us a very good confidence among our patients that they will be aligned in a proper position when they are doing exercises. During the pandemic, we have been giving lot of home programs and tele-rehabilitation. So this was a good way of maintaining the alignment of the segments and getting the exercises done. So I would summarize it that whenever you are exercising, please consciously activate your muscles. The structural integration among your middle and lower fibers of trapezius, your core muscles, and gluteus maximus activation is very important. Whether you are doing squats, whether you are doing lunges, whether you are going for long walks, it is not required to put 100% activation of those muscles when you're going for walk. Even of these muscles which are supporting your spine should be done. The more you use, less chances that you would go into any form of injury. So this was from my side. Any questions?
Thank you, Dr. Anjali. That was very lucid presentation, and you have given very important tips and very simple and doable exercises, which even in between two cases we can do. And also importance of posture, good posture. Because most of the times we stand in the OT limping one leg, or we keep flexing our neck. So I think that that we have to correct consciously. Thank you so much. Any questions, Manisha?
No, I don't see any questions in the chat box, but thank you, Anjali. That was a really very nice talk. And as anesthesiologists, when we are young, we don't feel the aches and pains. But now with the increasing age, I'm sure some niggling pains here and there are becoming more common. The joints are creaking, they are groaning. But Krishna Doshi sir had the loudest laugh. I think he's the most senior most here, and he knows it better than anybody. Yeah, but
absolutely, you're absolutely right.
but sir, you are still very fit and energetic. And I remember few months back, we met at a party where you were the You were dancing continuously. So can you tell
Manisha.
us? Yes, sir.
Manisha, I had one suggestion for this all the anesthesiologists who are in
Yes,
the.
sir.
See, in my 30 years of practice, what I have learned in ergonomics in anesthesia, that whenever you give anesthesia, at that time you stand up. But whenever you get a chance in the sitting in the operation theater, you must have a chair, not a stool. And you must have a very good chair in front of the head. And you sit down very peacefully, and you have a monitors, you have a IV line, now you have a ventilator. So most of the anesthetists, why they are doing early seasonal practice, because they are having a knee problem or some cervical problem or something like early retirement. So believe me, this is my personal experience, that if you are standing continuously in the theater for watching the patients, then it is a long standing journey like that. It will create a havoc in your body system. So whatever doctor said, the previous speaker, it is an excellent presentation and I very liked it.
Yeah. Sir, and I think to some extent, this mobiles that have come into our OT is a boon and a bane also, because we are learning a lot of things in the OT, but we are like this most of the time. So that Facebook picture with the head down is what is happening with a lot of us, and the neck is giving problem to a
Now
lot.
you don't believe that our surgeons are also, whenever there is a phone call, then they also with their Bluetooth or something like that, they also attend during operation.
Yes.
Yeah.
True, sir. That is very true. Anybody has anything more to say? We have some time. I was a little watchful of the time this time, because there's another program at 9. But we still have some time. If anybody has any inputs to give, they are most welcome. Dr. Doshi, sir, would you like to say something?
I think these talks were very informative, very good. And as far as the Tiwa is concerned, the youngsters should first weigh the pros and cons of what they're going to do, because Dr. Tushar has been doing it for so many years. He's excellent in what he has done. But the combination of drugs, the new younger fellows should not start immediately with at the dosage that, where they cannot manage beyond that. So they should learn it slowly. It's a very good thing. And Anjali's physiotherapy exercises that she has told is superb, especially in the operation theater when you sit. Most of us sit on the stools where you cannot rest your back, and then you tend to hunch yourself. So what is right is sit straight, erect, go against the wall if need be, or as Dr. Tushar said, have a chair specimen which has got a back support. Once you have a back support, your hunching that stops immediately.
Yes.
So I think these are very important things which one can carry for donkey's years afterwards.
Yes.
Very,
your
very
experience.
True. Yeah. Nina, can I give the vote of thanks, or you want to
Yes,
say
please.
something? Yeah.
Please. It was excellent.
Can I ask one question to Dr. Tushar?
Yes, please.
Madam.
Wonderful. Yeah.
Sir, this magnesium sulfate, now I wanted to ask, even for small cases, small duration cases, like
that
20
I have,
minutes,
that I
that
have
also
mentioned.
you can use?
No, that I have mentioned. I am using in 90% of the patients. When the case is less than 30 minutes, then at that time I am not using magnesium sulfate. I use only dexamethasone, because at that time the patient does not read, because it's a very small procedure, like something cystoscopies or gastroscopies or something like colonoscopy. In my practice, I am telling you. So at that time magnesium is not required. But whenever you get a intubated patients or IGL, supraglottic airway, or long-term anesthesia with some airway procedures or something like that, at that, like mastectomy or some tonsillectomy, ENT practice, I always give magnesium sulfate. Lot of noise is there. So I restricted myself with, and I don't give below 5 years old child also, to be very frank, because at that time some effect is potential.
Tushar sir, you have muted yourself, I think.
No, somebody muted me. Okay. So best practice is give, if the procedure is prolonged more than 20 to 30 minutes, intubated patients, laparoscopy, ENT surgery, urology, and what I will tell you also, in regional anesthesia, I am using intrathecal magnesium sulfate. So this is also very common practice with me. I had given to my father also for this DHS in orthopedy. The excellent effect. Post-operative analgesia is very good.
I would say Tushar Bhai is very, very innovative.
Oh, madam, it is already in the pharmacologic book. But
Yeah,
believe
yeah.
me, my message to this conversation:
Huh.
don't be afraid of anything
Yes.
you practice, because you are a life giver. You are not a life taker. You are
Yes.
sitting in between the death and life. Whenever you practice this anesthesia, the patient is surrendering you. So you must have all the equipments with you. Whether suppose cardiac arrest is there, you are in the theater, you have a defibrillator, everything. So don't afraid. Even some patient, some my colleagues are telling कि dexmedetomidine से तो bradycardia बहुत हो गया, उसका 45 हो गया, मैं कैसे उसको लूँ? मैंने बोला 45 is a normal for people. If the restless pulse is there at the middle of the night, then that pulse is going below 30. So they are also surviving. So it is not a question of usko, when propofol came, people were not using. Now each and every anesthetist, 100% of the anesthesiologists are using propofol. Why? Because now it is a common practice. Like dexmedetomidine also will be, it's a very good molecule, and 9 companies are came in India with the dexmedetomidine. Believe me, in UK it is still in the cupboard. You have to ask the permission to take the dexmedetomidine. Here it is available 500 rupees. There it is 2500 rupees per ampule. That is the, so we are very fortunate that we have a dexmedetomidine. Unfortunate, no remifentanil.
Thank you, sir. So I have one more question. You mentioned you are doing lots of OGD scopies, more than
Yeah.
10,000 or something you mentioned. Now
Yeah.
I am forever struggling with my ERCPs, which I do only under
I will.
propofol.
I have a
what will
very
be-
nice presentation. I have a very nice presentation on ERCP, and ERCP is, believe me, in only one procedure I am frightened. That is ERCP, because at that time our airway is not under control. So now gastro LMA came in the market, and I have started using gastro LMA in Baroda, and it is a wonderful. In one pot we have to give ventilation, in one pot they put a, so airway, we are sharing the airway with the gastroenterologist, and that way. Till when I was not having this gastro LMA, how I was practicing, you know, once the patient was given some sedation, at that time people were, my gastroenterologist was putting endoscope, then patient will be at the left lateral position or semi prone position, and after that I was giving more sedation, because when you give deep sedation pre procedure, before introduction of this GOP. So this is my personal experience. Okay, after prone position you can monitor the patients and you can give guarded, and little bit ketamine, that is a wonderful, at least 10-15 milligram, and this gives it. The unfortunate part is they are using more Buscopan and the air insufflation. So at that time patient getting pain, and airway is always compromised. I say that 90% of the patient get hypoxia, even SpO2 is below 90. So I am only afraid. So now I am very built to that gastro LMS. This is 22,000 rupees is available in India now, and you can reuse for 50-60 times, but I have used more than 100 times now.
Yeah. Yeah, thank you, sir. Because that was one of the things that always, you know, I have a case for ERCP and I cannot sleep in the night, happens to me.
Yeah,
but
yeah,
but
ERCP is
gastro
very
yeah,
notorious.
very notorious, very notorious.
Notorious.
Thank you very much,
Thank
sir.
you.
Anybody else would like to say something?
Yeah,
or
Manisha,
any...
one question,
yes,
Manisha.
Yes, sir. Please, Dr. Godbole, sir.
Yeah,
Doctor,
this
sir,
is for
just
Dr.
one-
Choksi.
Yes, sir.
Any drug interaction between magnesium sulfate and muscle relaxants?
Muscle relaxant, I don't believe that. Muscle relaxants are different metabolism, and this magnesium sulfate has got a different. But such a, you may be right, some potential of effect in magnesium sulfate for the atracurium is there. But cis-atracurium, now I have shifted from atracurium to cis-atracurium, and now the cis-atracurium is very good molecule. So I never find the effect is itself is prolonged in cis-atracurium rather than atracurium. Atracurium gives 20 to 25 to 28 minutes of effect, first bolus dose, but this cis-atracurium gives almost around 35 to 40 minutes. But my long surgery, I am very much advantageous when I am using magnesium sulfate. So I have to give less dose. So fundamental rule is that whenever you use muscle relaxant, you give 80% dose. That's all. And repetition is also some less dose. That
Yeah,
is what my experience.
yeah. Because we haven't used magnesium sulfate with muscle relaxant so far. That's why
No,
the
everybody
worry was
in
there.
Baroda, more than 300 anesthetists now they keep magnesium sulfate in their weapon. That's all. There is one lecture I had given to ISA Borivali 3 years back. At
Yeah.
that time, more than 1200 anesthetists have gathered, and I think some of the anesthetists might have that Tendulkar, Ganesh Tendulkar was there. And at the second day, I got a call from Dr. Neon, Dr. Gupta sir. Yes, sir, what magic you have done in Borivali ISA webinar or this lecture that my 6,000 ampoule were sold in a one day.
That's
See,
great.
every anesthetist now started a magnesium, and in 3 years span, magnesium sulfate is even Western countries also this become a very standard. So there is a very good one article you must versatile drugs for the anesthesiologist. This is the heading: magnesium sulfate reemergence.
Yeah, yeah.
So there was one
So-
question in the chat box just now. What is the dose of intrathecal magnesium sulfate that you are using?
That is 50 to
Yeah.
100 milligram. 50
So
to 100
in-
milligram. So I take a 10 ml or 8 ml of distilled water and 2 ml of magnesium sulfate in 10 ml of 10 ml syringe, and out of that 1 ml I add in the bupivacaine. I mix it and I give. So baricity is not disturbed because bupivacaine portion is means 4 ml, so it might be diluted up to 80%, but still it is a hyperbaric, so effect is good. But the prolongation of the effect for analgesia up to 6 to 8, more than 6 to 8 hours or 12 hours up to. This is very common that magnesium sulfate you give and you will get a post-operative analgesia very nice way. Even IV magnesium also get good analgesia. It has got a very nice effect in every part of anesthesia corner. In induction, yeah, very good anti-shivering, anti-arrhythmic, everything.
Very true.
Thank
Thank you
you.
very much, sir.
Very nice
Yeah.
discussion.
Yeah, thank you very much, sir. We are nearing the end of our session.
Okay.
And I would like to thank Dr. Tushar Choksi, sir, for I just made one like Naresh Paliwal sir said, he and Tushar sir have never met. It is the same with us nowadays. Because of the pandemic, we have got to know many people, and I got to know you because of Facebook and Tiwa group.
Yeah.
And thank you very much for agreeing immediately to give a talk in our Thane ISA meet. And thank
I
you
would-
very much for sharing your PDF and being very generous enough to even share all the material that you have. And I hope, sir, you will allow some of us to come and
Yeah.
spend a day with you in your practice and learn something
Yeah, definitely.
directly.
My
I would
invitation
really
is
like to do that.
my invitation is to you catch me again for the artificial intelligence in anesthesia practice.
Definitely.
And beyond that, I am going to give first time in May in all over world one lecture that is not prepared by any anesthesiologist, and even metaverse in healthcare. The new era is coming in the anesthesia practice.
GARC, yes.
In
sir, I read that.
2030, that is one scenario I will tell you. Okay, Dr. Manisha goes in the her theater and she wants my help in her theater. I will be virtually present in her theater and I will be touching the patients. I will be giving the anesthetic agents. So it is called a metaverse anesthesia. Virtually, I will be present and you will see me as a virtually. So this is definitely a boom for the anesthesiologists.
We will look forward to that day, sir.
Yeah, thank you.
I also want to thank Dr. Anjali Puntambekar for taking the time out and being a part of our CME. In Thana, we have always tried to, have different topics together, so there is something for everybody. And currently with the fitness programs going on, the wellness, the mindfulness, the heartfulness, I think Dr. Anjali Puntambekar was the best person to have today. And of course, a big thank you to Dr. Krishna Joshi, sir. He always attends all our CMEs and blesses us. And he has a very, very special place in the hearts of Thana Anesthesia Society and ISA Thane. Dr. Manisha Katikar, madam, could not make it today, but she has sent her greetings and best wishes to us as usual. Thank you to Dr. Bhosle, sir, Dr. Samir Soni, Dr. Saleh, Dr. Naresh Paliwal, Dr. Jesse, the president of Navi Mumbai was also here, and all the delegates who took time off to come and attend our seminar. We are very, very grateful. Once again, I would like to remind all of you to participate in the Jito Marathon, which is for a very noble cause. I will share the details on WhatsApp group. Another announcement is that in the month of April, we have 2 CMEs, one on the 1st of April and one on the 7th of April. This time they will be with an added benefit of MMC points. So do keep the time off for that also. And I wish you a very good evening and thank you very much. Good night, everybody. Meenal madam.
Yes, fantastic program. Very nice program. And
Manisha,
Choksi sir was like
Manisha,
anything.
Minal, Manisha, Nilima, excellently done. Very good job. Keep it up.
Thank you,
Yes,
sir.
thank you, sir.
Thank you very much. There is one very nice program now at 10 o'clock again from Maharashtra State Chapter of ISA, in which there are 2 very good talks. One is by Dr. Swati Gadgil and the other is by Dr. Roshan Jahan Sheikh, whose story is worth listening to. So if you can have a quick dinner and join in again at 9 o'clock for this very, very excellent talks that we will get to hear. Okay, good night, everybody.
Good night.
Good night. Good
Very
night.
much. Thank you.
Hi, sir.
Thank you, Varsha. Thank you, Varsha. We can end the meeting now.
Bye, sir. Bye, Gurgule sir.
Bye, ma'am. Thank you, sir.
लागतंय तेव्हा साबुदाणा सुनेला नीट भिजवता आला नाही म्हणून जर सासू टोमणे मारायला लागली सकाळी उठून तर कसं चालेल. हे मी जस्ट एक उदाहरण देते की योगा करून निघाली सासूबाई, देवळातलं कीर्तन ऐकून निघाल्या. हल्ली देवळात कीर्तन ऐकायला कोणी जात नाही बरं का. केमिस्ट्री त्यांची पण वेगळी असते, ती कट्ट्यांवर असते. ज्येष्ठ नागरिक कट्ट्यावरती सगळे सिनियर सिटीझन एकत्र बसून घरात काय चाललंय त्याच्या गप्पा मारत असतात. कोणीतरी खोटा हा म्हणत असतं, नाही आमची मुलं ना अमेरिकेत आहे, कॅनडात आहे, आमची सून अशी आहे, पण पाठीमागे घरी आलात की ते सेम टोमणे असतात. सो ऑन स्क्रीन, ऑफ स्क्रीन, ऑनलाईन, ऑफलाईन, ही जी केमिस्ट्री आहे ना, नवरा बायको फेसबुकवर अनाऊन्स करतात एकमेकांच्या अॅनिव्हर्सरी बद्दलच्या विशेस. मग ते वेगवेगळ्या ठिकाणच्या पोजेस देऊन, वेगवेगळ्या ठिकाणी जाऊन तुम्ही कसं सेलिब्रेट केलंय, हाऊ मेनी केक्स यू हॅव कट अँड व्हॉट ड्रेसेस यू हॅव वोर्न, हे सगळं तुम्ही ऑनलाईन दाखवताय, पण तितक्याच इंटेन्सिटीने ते ऑफलाईन आहे का, हा माझा प्रश्न असतो नेहमी. आणि ऑफलाईन ते जर तेवढ्याच इंटेन्सिटीने तुमचं प्रेम असेल तर ते इतकं तुम्हाला जाहीर करणं गरजेचं आहे का. नवरा बायकोच असं नाही, अगदी मुलं सुद्धा आई वडिलांच्या डेथ अॅनिव्हर्सरीचे फोटो टाकून 10 वर्षापूर्वीची झालेली डेथ असेल तरी सुद्धा ते फेसबुकवरती खूप मोठं काही काही लिहिलं असतं, भरपूर मन व्यक्त केलेलं असतं. पण माझं म्हणणं आहे की ते आई वडील जेव्हा जिवंत होते तेव्हा त्यांच्यासाठी आपण काय केलं हा विचार महत्वाचा आहे. ते असताना आपल्याच्यानी चुका व्हायला नकोत, मुलं आपल्या जवळ असताना आईवडिलांच्यानी चुका व्हायला नकोत. मग मुलं दूर निघून गेल्यानंतर त्यांच्याबद्दल तुम्ही काहीतरी छान सांगत राहणं किंवा प्रोजेक्ट करणं की हाऊ दे आर वेल सेटल्ड अँड दे हॅव सो मच मनी अँड दे आर सेंडिंग सो मच मनी अँड आय एम स्टिल हॅपी. People staying in senior citizen homes, or there are places like hostels where they all buy flats together, purchase kartat ghar ekatra, and they all stay together in a colony just to feel protected, just to have the medical facilities if they need, to have friends of the same age to share their woes. पण मनातलं दुःख काही कमी झालेलं नसतं. त्या ठिकाणी जेव्हा तुम्ही जाल अशा कॉलनीमध्ये तेव्हा जाणवतं, प्रकर्षाने जाणवतं की तिथे एंटर झाल्यापासून तुम्ही कुठल्याही कोपऱ्यात तिथे फिरलात तरी तुम्हाला 60च्या पुढचीच माणसं फिरताना दिसतील. देर वुड बी लॉट्स ऑफ हेड्स विथ व्हाईट हेअर अँड नो किड्स अराउंड. यु नो, दिस रिमाइंड्स मी ऑफ वन थिंग की जिथे तुमची मुलं लहान असताना तुम्ही त्यांना रेसिडेन्शियल स्कूलला पाठवायला बघता आणि ते मूल रेजिस्ट करत असतं. त्याला चांगलं शिक्षण मिळेल, गुड क्वालिटी एज्युकेशन मिळेल, त्याला शिस्त लागेल, डिसिप्लिन लागेल म्हणून तुम्ही त्या मुलांना हॉस्टेलला पाठवता, पण त्या मुलाला ते आवडतंय का. तारे जमी पर मूवी हॅज शोन इट व्हेरी विविडली हाऊ दॅट स्मॉल चाइल्ड डज नॉट वॉन्ट टू गेट सेपरेटेड फ्रॉम हिज मॉम, बट द फॅमिली इज इन्सिस्टिंग की तिकडे गेलं पाहिजे त्यांनी. डिसिप्लिनसाठी. आणि मग तिथे गेल्यावर काय असतं, त्याच्याच एजची तशीच मुलं सगळी एकत्र राहत असतात. त्या सगळ्या एकत्र राहणाऱ्या मुलांमध्ये आनंदच असतो का, हा प्रश्न कधी कोणी त्यांना विचारतच नाही. आर दे मिसिंग आउट ऑन समथिंग? डू दे वॉन्ट समथिंग एल्स? डू दे वॉन्ट टू बी विथ द फॅमिली अँड गेट एज्युकेशन, गुड एज्युकेशन? This is never asked. And same is the story with senior citizens today. When the children just go away, आपला देश सोडून निघून जातात किंवा गावात असले तरी वेगळे राहतात किंवा दुसऱ्या शहरांमध्ये राहतात आणि आई वडील एकटेच राहत असतात. आणि ते उसना अवसान आणून लोकांना सांगतात, आम्ही खूप हॅपी आहोत, आमच्याकडे देवाने दिलेलं सगळं काही आहे. जेव्हा की प्रत्येकाच्या मनात ते बोचत असतं की मला माझी मुलं, माझी नातवंड माझ्या भोवती हवी आहेत. तिथे कुठेतरी एक इम्बॅलन्स होतो. एकच केमिकल एका ठिकाणी राहून चालेल का? फॉर अ गुड रिॲक्शन देर हॅव टू बी 2 केमिकल्स, 3 केमिकल्स, तरच ती रिॲक्शन होईल. सिंगल केमिकल being somewhere is no reaction, is no life. It's not a happening situation. So all 3 generations being together is always a win-win situation for every family, and we have to strive to achieve that. मी म्हटलं तसं शक्य असेल तेव्हा तुम्ही एकत्र राहा, शक्य नसेल तरी ऍक्सेसिबल राहा, बी क्लोज टू इच अदर. शेजारचे फ्लॅट्स घेऊन राहा, म्हणजे तुम्हाला तुमची प्रायव्हसी पण राहते आणि तुम्हाला मदत लागली तर मदतही करता येते एकमेकांना. यू ऍटलीस्ट सी इच अदर एव्हरी डे. You need not spend long hours together. Few minutes together is also good enough. Just a glimpse of your child or glimpse of your parents gives you that happiness and comfort ki yes, we are together. जगात आहे दुसरं काय हा विचार तुम्ही हेडॉनिक गोष्टींकडे, म्हणजे तुम्हाला मटेरियल गोष्टींकडे अट्रॅक्ट होऊन तुम्हाला पैसा हवाय, गाडी हवी आहे, घर हवंय, खूप प्रॅक्टिस हवी आहे, तुम्ही वर्कहॉलिक आहात, 24 तास हॉस्पिटल आहात किंवा तुमच्या ऑफिसेसमध्ये आहात जिथे काम करताय, घर आहे, म्हणायला कुटुंब आहे, म्हणायला बायको आहे, मुलं आहेत, पण तुम्ही त्यांच्याशी खरोखरी किती इन्व्हॉल्ड आहात? किंवा घरी आल्यानंतर जर का मुलाचा आईचा काहीतरी चालू असेल डिस्कशन अभ्यासावरून, आई रागवतीये मुलाला, तर वडिलांनी येऊन काय करायचंय? अजून मुलाला परत रागवायचंय का? दिस इज व्हॉट नॉर्मली हॅपन्स because we carry the stress that we have outside into our home. So if you see that something is going wrong in the family, you just come in to add into it. But then you are being a bad catalyst. कुठे फायर लागलाय तिकडे ऑक्सिजन बनू नका. Try to be a fire extinguisher. Just be quiet or just don't do anything. Inert राहा. Let them handle it between themselves. जे काय घरात होत असेल ना ते त्या 2 व्यक्तींना आपसामध्ये हँडल करू द्यावं. ती तेवढी मुभा द्यावी. त्या प्रत्येकाला तेवढा अधिकार असतो एकमेकांवर. मुलांना सुद्धा व्यक्त होण्यासाठी तसं वातावरण लागतं. इफ ऑल द टाइम देर आर पेरेंट्स हु आर डोटिंग, हु आर कंटिन्युअस कॉन्स्टंटली एक्सप्रेसिंग देअर विश की तुला एवढे मार्क मिळाले पाहिजे, दॅट यू हॅव टू गेट इन टू बेस्ट ऑफ द कॉलेज, दॅट यू हॅव टू बिकम अ डॉक्टर, अँड दिस विश is not secretly but very openly expressed all the time. The child is under pressure. कुठे आहे फ्रीडम टू एक्सप्रेस? त्या सुनेला सुद्धा घरातल्या जर गुदमरत असेल त्या वातावरणामध्ये, तिचं माहेर वेगळं आहे, तिचं सासर वेगळं आहे, सवयी वेगळ्या आहेत, तिच्या सवयी जर ऍक्सेप्ट होत नसतील नवीन घरामध्ये, ऑल द टाइम इफ दिस फॅमिली इज ट्राइंग टू टेल हर आपल्याकडे असं असतं, आपल्याकडे असं असतं, आपल्याकडे असं असतं, अरे तिच्या घरी काय होतं तेही समजून घेणं गरजेचं असतं त्या फॅमिलीने. मला वाटतंय तुम्हाला हे सगळं पटत असेल, कारण प्रत्येक स्त्री आपल्यापैकी जी आहे ही यातून गेलेली असते की आपण माहेरून जे काही जगलो असतो, जे काही 20-25 वर्ष, आता काळ वाढलाय, आता 30 वर्ष माहेरी असतात बहुतेक मुली, कारण 27, 28, 30च्या आधी लग्नच करत नाहीयेत. आणि कधी कधी तर त्यानंतर करायचंच नाही लग्न अशा निर्णयाला येतात, कारण मग विचार पक्के होतात की नाही, माझं आता कुठेच ऍडजस्ट होऊ शकणार नाही मी दुसऱ्या कोणाबरोबर. एका याने असं वाटतं की जुन्या पद्धती बऱ्या होत्या, थोडंसं लवकर लग्न झालं तर किमान एक, म्हणजे इट्स नॉट कंपल्सरी दॅट यू नीड टू गेट मॅरिड. आय अग्री. इट्स नॉट नेसेसरी दॅट यू नीड टू हॅव अ हजबंड ऑर अ वाईफ. यू कॅन लिव्ह ऑल बाय युअर सेल्फ, येस, बट देन यू हॅव टू डिफाईन व्हॉट इज. Am I right? It is again an individual decision. Like we are now openly accepting now we are openly accepting ki gays आहेत, lesbians आहेत, people are into live-in relationships, into anything. कायद्याने सुद्धा 377 मॉडिफाय केला, तो लिगली नाही केले. मॅडम, हे थोडं रेकॉर्डिंगचा इश्यू काय होत आहे, डिस्टर्ब होत आहे. आय एम रिअली सॉरी टू से, बट
yeah, it is coming from Varsha.
येस मॅम, कोणीतरी को होस्ट आहे ना, ते क्लिक करते, स्टॉप करते.
हा, बिकॉज
प्लीज स्टॉप नका करू.
Okay.
yeah, sorry. So like we have been accepting all kinds of relationships today, आणि त्या ओपनली एक्सेप्ट कराव्या असं मला माझ्या लेक्चर्स मध्ये कॉलेजचे स्टुडंट सांगतात. Few years ago, when this was not discussed so much, and in my gender sensitization lectures, I used to say that yes, focus on your studies, focus on your career, at least till the age of 25. Else तुम्हाला रिव्हर्स मध्ये गाडी न्यावी लागेल. आधीच प्रेम केलं, आधीच सगळे उद्योग केले, अभ्यास राहिला बाजूला, काही करू नाही शकला, तर नंतर करिअर इस्टॅब्लिश करणं डिफिकल्ट होतं. सो यू हॅव टू गेट मॅरिड, अ गर्ल विल फाइंड अ बॉय वगैरे असं सगळं उल्लेख केल्याबरोबर एक मुलगी उभी राहिली आणि मला म्हणाली, वाय अ गर्ल शुड फाइंड अ बॉय ऑलवेज? म्हणजे तिने एका मुलाशीच लग्न करणं हे कंपल्सरी असं तुम्ही म्हणताय का मॅडम, असं मला विचारलं होतं. आय जस्ट इमिडिएटली रिट्रॅक्टेड माय स्टेटमेंट. आय सेड नो नो नो, फ्रीडम आहे म्हटलं सगळ्यांना, ज्यांना जे चूज करायचं लाईफमध्ये यू कॅन चूज, नॉट अन इश्यू. But this is what I had to say, because this is today's generation. They have questions over everything and they expect us to accept everything that they do. ठीक आहे, हरकत नाहीये, पण ऍटलिस्ट आपल्या वागण्यातून आपण एक चांगलं उदाहरण त्यांच्या पुढे ठेवायचंय. म्हणून ही जी केमिस्ट्री आणि फॅमिली इक्वेशन जे आहे, 3 जनरेशन्स एकत्र राहताना जर सिनियर जनरेशननी नवीन मुलांच्या विचारांना जर का कायम त्याच्यावरती क्रिटिसिझम केलं, तर ते रिॲक्शन तिकडेच थांबणार आहे. देअर वोंट बी एनी केमिस्ट्री. इवन लहान मुलांच्या लहान लहान गोष्टी ते शाळेतनं आल्यावर जेव्हा आई वडिलांना, आजी आजोबांना सांगत असतात, तेव्हा जर का आपण लक्ष देऊन ऐकलं नाही, त्यांचं इग्नोर केलं, म्हणजे अननोईंगली, नकळत आपण म्हणतो की अरे रोज येऊन ही पोर मला सांगते, आज हा माझ्याशी भांडला, आज माझा डब्बा सांडला, आज टीचर रागवल्या, आणि ह्या लहान लहान गोष्टी आपण इग्नोर करतो कारण आपल्याला वाटतं त्याला महत्व नाहीये. पण ही गोष्ट त्यांच्या मनामध्ये खोलवर रुजते आणि मोठं झाल्यावर त्यांच्या आयुष्यात घडणाऱ्या मोठ्या गोष्टी पण ते आपल्याला सांगणार नाहीत, हे गृहीत धरा. सो इफ यू वॉन्ट एव्हरी पर्सन इन द फॅमिली टू शेअर देअर पर्सनल लाईफ विथ अस, एकच करायचं आहे की कायम आपले कान त्यांच्याकडे असले पाहिजे. बी अटेंटिव्ह, लिसन टू देम. और इवन तुमच्या नजरेने तुम्हाला कळतं की समोरची व्यक्ती डिस्टर्ब्ड आहे, आज ते इग्नोर करू नका. तुमच्या कुटुंबातल्या कुणाच्याही चेहऱ्यावरचा एक्सप्रेशन जर बदललेलं असेल, इफ यू फील दिस पर्सन इज नॉट टॉकिंग टुडे, इज नॉट ईटिंग वेल, सीम्स टू बी विथड्रॉन, खोलीत जाऊन बसलंय, तर ती गोष्ट स्वतःच्या तुमच्या कामाच्या व्यापामध्ये तुम्ही इग्नोर केली असं होऊ देऊ नका. कारण ते खूप महत्वाचं आहे आणि मग नंतर त्या गोष्टी इतक्या पुढे जातात की तुम्हाला थेरपिस्टची गरज लागू शकते. वी हॅव सीन गुड एज्युकेटेड पीपल म्हणजे आता कॉमन मॅनचं जाऊच द्या, आपण अनेस्थेसिओलॉजिस्ट आहोत. वी नो हाऊ मेनी ऑफ अस हॅव फेल्ट की आय डोंट हॅव एनी सपोर्ट इन दिस वर्ल्ड अँड दे हॅव एंडेड देअर लाईफ. आणि ह्या अशा अनेक घटना ज्या आधी घडल्या, दरवेळेस मला वाईट वाटलं की का काउन्सिलिंग नाहीये, का कम्युनिकेशन नाहीये. इज देअर अ कम्युनिकेशन गॅप? आर वी फेलिंग समवेअर? मग हे फेल नाही व्हायचंय. मुलांकडनं जशी मार्कांची अपेक्षा करतो ना, तसे स्वतःलाही तुम्ही 100पैकी 100 देऊ शकणार आहात का, हे प्रत्येकाने विचार करायचा आहे. एव्हरी डे इट्स अ एक्झाम फॉर अस. प्लीज अंडरस्टँड. Living together, maintaining a family, having a good cordial relation, and not only within your family but with your colleagues also outside. प्रत्येक गोष्ट तुमचा स्वभावच त्याच्यावरती ठरतो की तुम्ही कसं स्वतःला मोल्ड करताय. तुम्ही समोरच्यातल्या चांगल्या गोष्टी बघून त्याला चांगलं म्हणायला शिकताय का? तेवढं तुमचं मन मोठं आहे का? की तुम्ही समोरच्यातल्या खोड्या काढून त्याच्याबद्दल गॉसिप करताय का? जसं मगाशी म्हटलं, सासूने जाऊन सुनेबद्दल गॉसिप करणं, सुनेने ऑफिसमध्ये जाऊन सासूबद्दल गॉसिप करणं. आय वुड लव्ह टू टेल यू, शेअर वन स्मॉल थिंग नाउ. माय सन गॉट मॅरिड दिस डिसेंबर. मी आत्ताच सासू झाले, नवीन एकदम फ्रेश. आणि माझी सून जेव्हा तिच्या ऑफिसमध्ये रिझ्यूम झाली, तर तिला पहिलं सगळ्यांनी काय विचारावं, तुझी सासू कशी आहे ग? आणि कुठे गेली, नातेवाईकांकडे गेली की एकच प्रश्न, तुझी सासू कशी आहे? ओ माय गॉड. अँड दॅट रिअली ट्रबल्ड हर सो मच की ती चिडचिडली आणि मला फोन केला. आई म्हणे, असं का सगळेजण फक्त सासूबद्दलच विचारतात? कोणी मला नंदेबद्दल विचारत नाहीये, सासरे कसे आहेत, फादर इन लॉ कसे आहे, सिस्टर इन लॉ कशी आहे, तुझ्या नवऱ्याला भाऊ आहे का, बाकी फॅमिली. Nobody is interested in knowing anything else in the family except how is your mother-in-law. So she was amused and then she had her answer ready. तिने असं छान रटवून ठेवलं होतं. ती सगळ्यांना सगळं काही सांगते, माझ्याबद्दल कौतुकाने सांगते की काय काय करतात माझ्या सासूबाईंवर, आजच्या स्टाईलनी सांगते. त्या ना एकदम चिल्ड आहेत, एकदम आपल्यासारखे आहेत म्हणे, असं सांगून ती कौतुकाने त्यांना गप्पा करते. सी द chemistry between us, the relationships that we develop, the innocence that we treasure, ह्या गोष्टी खूप, द ट्रान्सपरन्सी while giving them their privacy. प्रत्येकाने प्रत्येकाला ऑनेस्ट असणं एकमेकांशी गरजेचं जितकं आहे तितकं प्रायव्हसी देणं पण गरजेचं आहे. प्रत्येक वेळेस जाऊन एखादी व्यक्ती जर आपल्या कुटुंबातली रडताना आढळली, नाराज आढळली, तर जाऊन लगेचच्या लगेच रागवू नका की काय झालंय सांग, काय झालंय सांग, एस्पेशली इफ दॅट इज युअर चाइल्ड. आपली मुलगी, आपला मुलगा लहान असताना जर असं झालं ना, तर आई वडिलांना पेशन्सच नसतो. आत्ताच्या आत्ता सांग काय झालंय, आत्ताच्या आत्ता सांग तू कुठे जाऊन आलीस. असं नसतं ते, आत्ताच्या आत्ता होत नाही. काही केमिकल रिॲक्शन्स स्लो असतात, त्या स्लोच राहू द्यायच्या असतात. त्या फास्ट केल्या ना तर एक्सप्लोजन होतं. सो त्या स्लो रिॲक्शन्स कशा राहत असतील, त्याच्यातनं कसं चांगलं निघेल. तुम्ही केव्हा फक्त केअरिंग आणि सपोर्टिव्ह राहायचंय एकमेकांसाठी, केव्हा थोडंसं स्ट्रिक्ट राहायचंय, हे जमलं पाहिजे, हे समजलं पाहिजे, हे उमजलं पाहिजे, कळलं पाहिजे आणि वळलंही पाहिजे. कळतंय पण वळत नाही हे एक्सक्यूज नेहमी द्यायचं नाही. आणि अनेक वर्ष एकत्र राहिल्यानंतर ना आपोआपच ते प्रेम वाढतं. आणि भांडणं होतात, ती होणार आहेत, ती होऊ द्यायची. थोड्या थोड्या ठिणग्या उडणारच आहेत, त्याच्याशिवाय आयुष्याला मजा नाही. फक्त हळू आवाजात भांडायचं बरं का, नाहीतर चार भिंतींच्या आत भांडण झाल्याबरोबर पहिला प्रश्न मग नंतर मनात येतो, शेजाऱ्यांनी ऐकलं असेल का, बाजूच्या बंगल्यात ऐकू गेलं असेल का, रस्त्यावरनं कोण जाणारे ऐकलं असेल का. ठिणग्या उडू देत छोट्या छोट्या बरं का, एकदम मोठा बॉम्ब फटाका नको. छोटे छोटे भांडणं असतील पण त्यातून प्रेम वाढतं. आजच्या नव्या पिढीला पण एक सांगायचं आहे की इमिडिएटली या निर्णयाला यायचं नाहीये की आपलं पटत नाहीये. विल इट वर्कआउट पासून सुरुवात करायची नसते नात्याची. इट विल वर्कआउट. वी हॅव टू स्टे टुगेदर. कुठलाच माणूस 100% चांगला किंवा 100% वाईट मिळूच शकत नाही. प्रत्येकाच्या वेगवेगळ्या क्वालिटीज असतात, कमी जास्त प्रमाणात. इफ यू लुक इन द मिरर यू विल नो की स्वतःच्या पण किती निगेटिव्ह पॉइंट्स आहेत. तरी आपल्याला कुटुंबातले बाकी लोक झेलतात ना, समाजातले इतर लोक, आपले कलिग्स आपल्याला टॉलरेट करतात ना. इट्स नॉट दॅट वी आर ऑल परफेक्ट. नोबडी कॅन बी परफेक्ट. सो दॅट इज आय एम सेइंग, जरी टायटल असलं अ परफेक्ट इक्वेशन, इट कॅनॉट बी अ परफेक्ट इक्वेशन, माइंड यू. अँड नेव्हर स्ट्राइव्ह टू मेक इट अ परफेक्ट इक्वेशन. Just try to make it a happy situation. Can we do that? Yes, we can do that. So happy situation करण्यासाठी ज्या बेसिक गोष्टी आपल्याला करायच्या आहेत त्या आपण पाळायच्या आहेत, ते नियम थोडेसे पाळायचे आहेत आणि असाच आपण आनंद एकमेकांना देत राहायचा आहे. मला मॅडमनी सांगितलं होतं की वी हॅव टू स्टिक टू टाइम लिमिट 20 minutes. सो माया मॅडम, डू आय हॅव सम मोर टाइम और आय शुड एंड? व्हॉट एव्हर. Madam, I cannot hear you.
Hello, madam. हाँ, बोला बोला.
I just wanted to know how much time I have because we started.
Madam, we are running behind the schedule.
I know, so I think I will end.
We started late also, so let's
exactly.
finish it off.
That is why I'm not going ahead further now. But the take-home message is कि there is no perfect equation. So chemistry तुमची जी काही असेल ती छोट्या छोट्या ठिणग्या उडत राहिल्या तरी त्या होऊन देत. स्लो रिॲक्शन्स या स्लो रिॲक्शन्सच राहू देत. अँड कॉर्डियली राहून हॅपीनेस कसा तुम्हाला त्या इक्वेशन मध्ये आणता येईल एवढंच बघायचंय. सो स्ट्राइव्ह टू मेक इट अ हॅपी इक्वेशन, नॉट अ परफेक्ट इक्वेशन. दॅट इज अ फॅमिली केमिस्ट्री. स्टे टुगेदर, स्टे हॅपी. गॉड ब्लेस ऑल ऑफ यू. थँक यू सो मच.
Thank you, madam.
Thank you, Swati Madam, for a wonderful talk. As usual, it's our pleasure to listen to you always. Madam, I request you to accept the floral e-bouquet as a token of gratitude from our branch. Varsha?
Thank you so much. Thank you.
Thank you, ma'am.
Loved
Thank
all
you.
the orders that you've given.
Thank you, ma'am. Moving ahead, I request our president, Dr. Maya Bhalerao, madam, to introduce our next speaker and carry ahead our program. Maya, madam, please.
I'm just sharing the slide. Can you see Seema and can you listen to here?
Yeah.
Am I audible?
Yes, madam, we can see your slide. Yes, madam, you're audible and we can listen to you also.
Okay, thank you so much. Respected ISA national dignitaries, Dr. Naveen Malhotra, sir, Anjali Bhure, madam, State President, MSc ISA, Dr. Manisha, madam, all dear delegates. I, Dr. Maya Bhalerao, President, bring warm greetings for each one of you from ISA Pimpri Chinchwad city. It gives me immense pleasure to introduce today's speaker and the dynamic doctor who has learned to fly high in the sky without boundaries, without wings. Friends, let me tell you, when she was just 15 years old, as a teenager, she has come across very devastating incidents. She was thrown into complete darkness in the life. There was no ray of hope to live, but she chose to challenge and took the challenge to change the circumstances. How? She asked God for strength. He gave her not only difficult situation, but he gave 3 worst combi pack to face and fight. And that's how he gave her strength. She fought for financial crunch and prejudice against the education. She fought for the legal system against her. And she fought for both bilateral leg amputation. Still, dropping out of school never happened to her, or maybe with her parents. Mother took her to school for theory and practical exams on a wheelchair in 12th standard. Her mother used to say, "Beta, do not see the disability, find out the ability in you." And that's how she went ahead. This is a picture taken by Mumbai Times. See the smiling face, see the confidence. संभव की सीमा जानने का एक ही तरीका है. संभव की सीमा जानने का एक ही तरीका है, असंभव से भी आगे निकल जाना है. और वो चलती रही. कोई चिराग की रोशनी जलाता नहीं सलीके से. कोई चिराग की रोशनी जलाता नहीं सलीके से, सभी को शिकायत तो हवाओं से होती है. फ्रेंड्स, शी डिड नॉट गेट नर्वस. मायूस नहीं हुई, क्योंकि उसकी आंखों में मंजिल थी. उसके आंखों में मंजिल थी, लड़खड़ाते और संभलते रहे. दिल की अरमा पूरे करने हवा में भी चलते रहे. Friends, because she stood third in Maharashtra under physically handicapped quota in CET for medical in 2011. She was refused admission as she had 89% disability certificate, and the disability criteria to get admission in medical was 40 to 70%. See the difference. और जिसने कोई हाई कोर्ट को कानून बदलने पर मजबूर कर दिया और फिर पूरी दुनिया के लिए एक मिसाल बन गई. She appeared before the court despite the physical and financial difficulties. हिंदुस्तान की आयरन लेडी, इनके लिए देश का 20 साल पुराना कानून भी बदल गया. Senior lawyer VP Patil attended her case pro bono, that means without charge. He showed the court that she can travel the court proceedings every time from Jogeshwari by a local train on herself. The court passed judgment in her favor and gave her justice. She created the history by changing the law restricting one's progress. MLA Amin Patel sponsored her medical education. Member of Parliament Kirit Somaiya went to Delhi and spoke to Union Minister JP Nadda about her, and he could proceed for the post-graduation admission for her. So friends, can you see the happiness on the face of her and as well as her parents? See the confidence. अगर किसी चीज को चाहो तो पूरी कायनात उसे तुमसे मिलने की कोशिश में लग जाती है, एंड दैट इज वेरी वेरी ट्रू. एवरीबडी हेल्प्ड हर. जितना बड़ा संघर्ष होगा उतनी ही शानदार जीत होती है. जितना बड़ा संघर्ष होगा जीत उतनी ही शानदार होती है. Really, this is really incredible. She has climbed all her steps like education, success, and now she speaks from her heart. She tells her story, which is really, really, we can elicit the emotional explosion within us. She has turned into an inspirational leader, and she has 2 billion views on YouTube. She has inspired many. You can see the pictures. The question is not who is going to let me. The question is not who is going to let me, but who is going to stop me. The unstoppable, the incredible, one and only one, Dr. Roshan Jahan Sheikh. I present to you Dr. Roshan Jahan Sheikh. And after listening to her, I'm sure you will wake up with a new vision tomorrow morning. Over to you, Dr. Roshan. Thank you so much. I'll stop sharing slide so that Roshan can take over.
Hello, good evening, everyone. Am I audible, ma'am?
Yes, ma'am, you are audible.
Yeah, but you are not visible.
No, she is visible, madam.
Yeah, she is visible. Yeah.
She is visible. Sunai bhi aa raha hai.
Okay. First of all, I thank Almighty Allah for all His blessings. And I thank SAPC, Dr. Maya, Dr. Anjali, Dr. Naveen, Dr. Manisha for inviting me here. And it is very, I am feeling honored to be here because all our doctor association. So this is the second time I am inviting in a association of doctors. So I am little bit nervous as I am a motivational speaker, but I respect all doctors, and being a doctor, I know how and कितना कीमती होता है हम सबका वक्त एक दूसरे के लिए. तो यहाँ पर जितने भी लोग हैं उन सबको मैं बहुत ज्यादा थैंक्स कहना चाहूंगी कि आप लोगों ने अपना कीमती वक्त निकाला और यहाँ पर मुझे सुनने के लिए आए. मैम ने बहुत कुछ मेरे बारे में बता दिया है, बट फिर भी मैं अपने आप को इंट्रोड्यूस कराना चाहूंगी कि मेरा नाम डॉक्टर रोशन जहां जवाद अहमद शेख है. मैंने MBBS किया है फ्रॉम सेठ GS मेडिकल कॉलेज इन KM हॉस्पिटल से, एंड 4 to 5 months ago I have cleared my MD pathology degree same सेठ GS मेडिकल कॉलेज इन KM हॉस्पिटल. तो मेरी जो स्टोरी है वो इसलिए यूनिक है एंड सब लोगों को लगता है कि मे बी ये इंस्पायर करती है तमाम लोगों को, बिकॉज मैंने अपनी लाइफ में काफी चैलेंजेस को से लड़ा है, मैंने फाइट किया है सबके साथ. बिकॉज मैं एक वेजिटेबल वेंडर की बेटी हूँ. फाइनेंशियली हम इतने स्ट्रांग नहीं हैं. हम 4 भाई बहन हैं और बचपन से ख्वाब था डॉक्टर बनना है, कोई मेडिकल फील्ड में जाना है, फैमिली को सपोर्ट करना है, लोगों को हेल्प करना है. तो 2008 में मैंने SSC में 92% लेकर टॉप किया इन जोगेश्वरी, और फिर 11th स्टैंडर्ड में एडमिशन लिया. मेरा जो घर है वो जोगेश्वरी में था और कॉलेज जो है वो बांद्रा में था. तो मैं लोकल ट्रेन से ट्रैवल करती थी डेली. इन 2008 7 अक्टूबर दिस वाज द डे जिस दिन मेरी जिंदगी बदल दी. मेरे सेमेस्टर के पेपर थे, मैं पेपर देकर कॉलेज से घर जा रही थी और मैंने रोज की तरह ही लोकल ट्रेन पकड़ी बोरीवली की. मैं फर्स्ट कोच में थी और ट्रेन 12 डब्बों की थी. बट जब ट्रेन चली और अंधेरी से ट्रेन स्टार्ट हुई तो मैंने सोचा मैं अपनी सीट से आगे आऊं नेक्स्ट स्टेशन, बिकॉज मेरा है जोगेश्वरी स्टेशन. तो मैंने सोचा कि मैं बस अपनी सीट से उठकर दरवाजे तक आने की कोशिश में वो एक लम्हे में मैं चलती हुई ट्रेन से गिर गई और मैं 2 स्टेशन के बीच में चलती हुई ट्रेन से गिरी और उस ट्रेन एक्सीडेंट में मैंने अपने दोनों पैर खो दिए. मेरा जो राइट लेग है वो अबाउ नी एम्प्यूटेड है और लेफ्ट लेग इज बिलो नी एम्प्यूटेशन. मैं वहां पर तकरीबन आधे घंटे तक रेलवे ट्रैक पर पड़ी रही विथ हैवी ब्लीडिंग, और मैं आई वाज कॉन्शियस बिकॉज मैं देख रही थी अपने आप को कि मेरा एक पैर रेलवे ट्रैक पर कटकर पड़ा हुआ है और बहुत ब्लीडिंग हो रही है। आसपास कोई भी नहीं था हेल्प के लिए बिकॉज मैं 2 स्टेशन के बीच में गिरी थी, तो लोगों को आने में काफी टाइम लगा। बट जब लोग आए तो उन्होंने हेल्प नहीं की मेरी, मेरे पास फोन भी नहीं था। फिर मुझे गवर्नमेंट हॉस्पिटल लेकर गए, वहां पर भी ऑपरेशन स्ट्राइक चल रहा था। मुझे ट्रीटमेंट नहीं मिला शाम तक। मेरा एक्सीडेंट सुबह में हुआ, मॉर्निंग में 10-11 o'clock, एंड देन इवनिंग तक मैं ऐसे ही ट्रॉली पर पड़ी रही। फिर जब मेरी फैमिली आई, मुझे प्राइवेट हॉस्पिटल शिफ्ट किया गया, वहां से मेरा ट्रीटमेंट स्टार्ट हुआ। 2-3 months आई वाज एडमिटेड इन द हॉस्पिटल, एंड ड्यूरिंग दिस फेज बहुत सारे लोग आए मुझे देखने के लिए, बहुत से कंसोल करते, बहुत से लोग ऐसी बातें बोलते कि आई वाज जस्ट 16 years old when this accident was happened। तो जब 16 साल की उम्र में एक फैमिली ऑलरेडी बहुत परेशान थी, फाइनेंशियली वीक थी, तो जब लोग आते मुझे देखने तो बहुत बोलते कि 16 साल की उम्र में दोनों पैर नहीं है बच्ची के, डिसेबल हो गई है लाइफ टाइम के लिए, ये खुद से मूव नहीं कर पा रही है, इसको तो जिंदा नहीं रहना चाहिए था, इसको ट्रेन एक्सीडेंट में मर जाना चाहिए था। बट ये सारी बातें मैं भी सुनती हूँ और आई वाज जस्ट 16 years old, तो मुझे भी नहीं समझ आता कि एक्चुअली में मैं जिंदा क्यों हूँ। मेरे 2 पैर 1 मिनट में मुझसे छीन गए। मतलब मैंने क्या किया था ऐसा जिंदगी में जिससे मेरे दोनों पैर नहीं रहे। तो मैं मम्मी से बहुत पूछती, अल्लाह से पूछती कि आपने जब मुझसे 2 पैर छीन लिए तो मुझे जिंदा क्यों रखा। लेकिन अम्मी ने मुझे बहुत अच्छे से मोटिवेट किया, मेरे टीचर्स ने मुझे मोटिवेट किया कि आपके सिर्फ 2 पैर गए हैं, यू हैव समथिंग इन यू जो मे भी आगे बहुत कुछ दुनिया को दिखा दे। तो मैंने उनकी बातों पर यकीन रखा, अल्लाह पर यकीन रखा कि अगर मेरे साथ कुछ बुरा हुआ है अभी, तो मे बी फ्यूचर में बहुत बड़ा हो मेरे लिए, इसका मे बी मुझे रिवॉर्ड मिले। तो ये एक सोच थी। और फिर मैंने अपना स्टडी क्विट नहीं किया, मैंने 11th किया, 12th किया व्हील चेयर पे, सीईटी में 3rd रैंक लिया ऑल ओवर महाराष्ट्र इन पीएच कोटा। और आई वॉज वेरी हैप्पी, माई फैमिली वॉज हैप्पी कि नाउ आई विल गेट एडमिशन इन मेडिकल, तो मेरा जो ख्वाब था वो पूरा हो जाएगा डॉक्टर बनने का। लेकिन यहाँ पर मुझे जो मेडिकल लॉ है उसके बेस पर मुझे डिनाई मिला मेडिकल काउंसिल से, बिकॉज आई वाज ए 96% डिसेबल, और टू गेट एडमिशन इन मेडिकल फील्ड you have to be a person should be 40 to 70% disabled. So I was more than 70% disabled, 96% disabled, so they denied me on a first day of counseling, एंड मेरे पास कोई ऑप्शन नहीं था। और कोई भी एक मेडिकल लॉ के अगेंस्ट कैसे जा सकता है। देन आई कॉल्ड माय ऑर्थोपेडिक सर्जन डॉक्टर संजय कंथारिया हु इज माय मेंटर टिल नाउ। ही इज नॉट जस्ट अ डॉक्टर एंड डॉक्टर पेशेंट का रिलेशनशिप है हमारे साथ, बट उन्होंने यहाँ तक मुझे गाइड किया, उन्होंने मुझे मेंटोरशिप दी अपनी, उन्होंने मुझे एक रास्ता दिखाया कि आप बॉम्बे हाई कोर्ट जाओ, बॉम्बे हाई कोर्ट में केस करो, और बॉम्बे हाई कोर्ट इज द लास्ट ऑप्शन फॉर यू। मैं बॉम्बे हाई कोर्ट गई 2011 मेरे राइट्स के लिए कि मुझे मेडिकल में एडमिशन मिलना चाहिए, बिकॉज तब तक मैंने अपने आर्टिफिशियल प्रोस्थेटिक से चलना सीख लिया था। मैं 2 क्रचेस यूज करती थी और बहुत ही अच्छे से मैं अपनी डेली लाइफ जी रही थी। बट ड्यू टू दिस लॉ आई वाज डिनाइंग एडमिशन। देन बॉम्बे हाई कोर्ट गई, बॉम्बे हाई कोर्ट में 2-3 महीने मेरी हियरिंग हुई। उन 2-3 महीनों में बहुत कुछ मैंने झेला, बहुत कुछ नाउम्मीद हुई, मायूस हुई, डिसअपॉइंट हुई मेडिकल लॉ से, डॉक्टर्स से, मेडिकल काउंसिल से कि ये जो लॉ है इसकी वजह से मुझे एडमिशन नहीं मिल रहा है डिस्पाइट ऑफ डूइंग ऑल थिंग। बट in 2011 in August I got Bombay order, बॉम्बे हाई कोर्ट के ऑर्डर इन माय फेवर। और उसके बाद से दिस वाज अ मुंबई फर्स्ट केस, मुंबई में ये पहला केस था कि कोई 96% डिसेबल गर्ल को एडमिशन मिला है मेडिकल में, वो भी बॉम्बे हाई कोर्ट की तरफ से। तो बहुत मीडिया कवरेज मिला और उसके बाद से मैंने MBBS क्लियर किया CHS मेडिकल कॉलेज KM हॉस्पिटल से, और मैं बहुत प्राउडली बोलती हूँ कि यहाँ पर जो इन्वायरमेंट मिला मुझे कभी भी ये फील नहीं कराया गया कि आप डिसेबल हो, आप 2 क्रचेस पे चल रहे हो, आप किसी से कम हो। मुझे टीचर्स ने काफी सपोर्ट किया, संजय ओक सर डीन थे उस वक्त, उन्होंने काफी सपोर्ट किया, MLA अमीन पटेल सर का सपोर्ट मिला फाइनेंशियली, तो काफी बहुत लोगों ने सपोर्ट किया और मैंने हिम्मत नहीं हारी। एज आप सब डॉक्टर्स हो, आप सबको पता है कि MBBS में एक उर्दू मीडियम से बिलोंग रखने वाली जो स्टूडेंट है उसको कितनी डिफिकल्टीज फेस आई होगी, बट मैं बहुत ज्यादा मैंने मेहनत की, अल्लाह पर यकीन रखी, और 2016 में मैंने फर्स्ट क्लास से अपना MBBS क्लियर किया। और उसके बाद मैंने सोचा कि क्यों ना, मैंने जब जब लोग मुझे देखने आते थे एक्सीडेंट के वक्त, तो लोगों का एक ये सोच होता था, एक थॉट होता है कि जो कोई भी कैंडिडेट या कोई भी पर्सन हो, अगर वो अपना एक्सीडेंटली या बाय बर्थ डिसेबल हो, स्पेशली एबल्ड हो, तो उस फैमिली को ये बोल कर जताया जाता है कि ये बच्चा आपके ऊपर बोझ रहेगा जिंदगी भर, ये ना सोसाइटी को कुछ दे सकता है, ना फैमिली को कुछ दे सकता है, ना अपने कंट्री को कुछ दे सकता है। बट मुझे ये लोगों की सोच चेंज करनी थी कि अगर मैं 96% डिसेबल होने के बाद, मेरे पास 2 पैर नहीं है उसके बाद, और अगर मैं फाइनेंशियली इतनी वीक हूँ, एक वेजिटेबल वेंडर की डॉटर हूँ, ये सारी डिफिकल्टीज फेस करने के बाद भी मैं डॉक्टर बन सकती हूँ, तो हमारी सोसाइटी में, हमारी कंट्री में ऐसे बहुत से लोग हैं जो छोटी छोटी चीजों से बहुत डिसअपॉइंट हो जाते हैं लाइफ से। एकदम छोटी, अगर हमारी जनरेशन जो स्टूडेंट की जनरेशन है उसमें अगर हम देखेंगे तो बहुत सारे, अगर किसी को कोई कम मार्क्स आया तो पेरेंट्स डिसअपॉइंट हो जाते हैं, स्टूडेंट डिसअपॉइंट हो जाते हैं अपनी लाइफ से, अपने करियर से, अपनी स्टडी से, कि मेरा मार्क्स कम आया है, मेरी लाइफ में ये प्रॉब्लम है, मैं फाइनेंशियली, मेरी माँ बाप की कंडीशन थोड़ी सी वीक है, तो मैं कैसे आगे बढ़ूंगा या बढ़ूंगी, तो मेरी लाइफ में बहुत सारी प्रॉब्लम्स है। तो ये जो डिप्रेशन है, ये जो सोशल स्टिग्मा है हमारी सोसाइटी में, मुझे इसको ब्रेक करना था, जस्ट टू शो एवरीवन कि इतनी सारी प्रॉब्लम्स, इतनी सारी ऑड्स के बाद भी जब मैं कर सकती हूँ, तो आप लोगों के पास तो 100% एबिलिटी है, आप लोगों के पास 2 पैर है, हाथ है, आंख है, नाक है, सब कुछ है, आप लोग एक कंप्लीट इंसान, ह्यूमन बीइंग हो, तो आप लोग क्यों नहीं कर सकते हो। तो ये प्रूफ मैंने MBBS पास करके कर दिया, बट मुझे मेडिकल की हाईएस्ट डिग्री भी अचीव करनी थी, तो मैंने सोचा मुझे MD में भी एडमिशन लेना है, तो मैंने नीट PG क्रैक किया, 3rd रैंक ऑल ओवर महाराष्ट्र लेकर, बट डिस्पाइट ऑफ क्लियरिंग MBBS विद फर्स्ट क्लास एंड टेकिंग रैंक 3rd रैंक इन नीट, मुझे अगेन डिनाई मिला मेडिकल काउंसिल से कि आप अभी भी 96% डिसेबल हो, आपको हम MD में एडमिशन नहीं दे सकते। This time I have only 2 days because this was a process was a online. So मेरे पास इतना टाइम नहीं था कि मैं बॉम्बे हाई कोर्ट जाऊं, 2-3 मंथ्स में बॉम्बे हाई कोर्ट की हियरिंग में लगाऊं, तो मेरा 1 साल वेस्ट हो जाता। बट अल्लाह कहीं ना कहीं से रास्ते क्लियर करता है, ये यकीन था मुझे। तो बस मेंबर ऑफ पार्लियामेंट किरीट सुमैया सर का कॉल आया, मैंने अपनी सारी प्रॉब्लम्स उनके सामने रखी, और आप बिलीव नहीं करेंगे कि उन्होंने ऑन द स्पॉट फ्लाइट ली, वो सेंट्रल हेल्थ मिनिस्टर दिल्ली गए, और दिल्ली में सेंट्रल हेल्थ मिनिस्टर के सामने मेरा एप्लीकेशन रखा, मेरी प्रॉब्लम्स उनको बताई, और वहां से ये जो मेडिकल लॉ है 40-70%, दिस इज अ 20 years ओल्ड लॉ, मेडिकल लॉ इन द इंडियन कॉन्स्टिट्यूशन का, और यू वोंट बिलीव कि ये जो लॉ है विद इन 2 days मेरी एप्लीकेशन पे चेंज हुआ, और ये इंडिया के इंडियन कॉन्स्टिट्यूशन में एक हिस्टोरिक डिसीजन लिया कि एक स्पेशली एबल कैंडिडेट की एप्लीकेशन पे कोई 20 साल पुराना कानून 2 दिन में चेंज हुआ। एंड देन अकॉर्डिंग टू माय रैंक आई गॉट सेम CHS Medical College in KM Hospital MD Pathology degree in 2018, and now I have completed MD Pathology degree with I have secured 4th rank in KM Hospital in Pathology department and 21st rank in all over Maharashtra in Pathology. So आप सबको ये सारी चीजें बताने का एक ही मकसद है कि हम हमारी जिंदगी में छोटी छोटी प्रॉब्लम से हार जाते हैं, छोटी छोटी प्रॉब्लम से डर जाते हैं, और इतने ज्यादा डरते हैं कि हम सुसाइड की बातें करने लगते हैं। हमारे स्पेशली जो बच्चे होते हैं आजकल के, वो मार्क्स से डर जाते हैं, पेरेंट्स ने थोड़ा कुछ ज्यादा बोल दिया तो उससे घबरा जाते हैं, जिंदगी से मायूस हो जाते हैं। तो मैं आपको कहूंगी कि आपको मायूस नहीं होना है, आपको घबराना नहीं है, आपको डरना नहीं है, क्योंकि आपके अंदर कहीं ना कहीं वो एबिलिटी होती है कि आप उस प्रॉब्लम से लड़ सकते हो। ऊपर वाला हमें उतना ही प्रॉब्लम देता है जितना हम झेल सकते हैं। और आज तक मेरी लाइफ में जितनी भी प्रॉब्लम्स आई है, मुझे ऐसा लगता है मैंने उसको पॉजिटिव वे में लिया है। बिकॉज मुझे ऐसा लगता है कि मेरा मुंबई का पहला केस था बॉम्बे हाई कोर्ट में, उसके बाद काफी जो स्पेशली एबल कैंडिडेट्स है उनको एक नया वे पता चला कि हम इस तरह से भी एडमिशन ले सकते हैं। और ड्यूरिंग MD एडमिशन ये जो लॉ है वो चेंज होके इतने सारे जो स्पेशली एबल कैंडिडेट्स हैं उनके लिए एक नया राह खुल गया कि उन्हें अब बॉम्बे हाई कोर्ट भी जाने की जरूरत नहीं है। तो मैं ऐसा सोचती हूँ कि मुझे ऊपर वाले ने अगर चुना है बहुत सारी डिफिकल्टीज के लिए, तो इसमें कहीं ना कहीं एक पॉजिटिव चीज है। मैंने हमेशा अपनी लाइफ में जो भी प्रॉब्लम्स आई है उसको पॉजिटिव वे में कंसीडर किया है कि मेरी वजह से अगर पीछे मेरे आने वाले मेरे भाई बहनों की राहें खुलती है तो क्यों ना मैं ही इन चीजों से लड़ूं। और आप सबको यहाँ पे बहुत सारे यंगस्टर भी हैं और सीनियर सिटीजन भी हैं, डॉक्टर्स हैं, नॉन मेडिको है। आप सबको एक ही एडवाइस देना चाहूंगी कि आप लोग अपने भगवान पर, अपने अल्लाह पर, अपने गॉड पर यकीन रखिए। हैव अ फेथ इन ऑलमाइटी कि आपको वो कभी भी अकेला नहीं छोड़ेगा। अगर आपकी लाइफ में अभी प्रॉब्लम्स है, छोटी है बड़ी है, बट 2 दिन बाद, 1 महीने बाद, 1 साल बाद उसका रिवॉर्ड आपको जरूर मिलेगा। और यहाँ पर जितने भी लोग हैं उनसे बस यही कहूंगी कि आप लोगों की लाइफ में अगर कोई गोल है तो उसको उसके लिए जी जान कर मेहनत कीजिए। बिकॉज अगर मैं 15 साल पहले ये सोचकर निराश होकर बैठ जाती और गिव अप कर देती कि मैंने तो कुछ ऐसा लाइफ में किया नहीं, तो मुझसे 2 पैर क्यों छीन लिए एक्सीडेंट में, और अगर मैं बेड रिडन ही रहती तो आज तक मैं बेड रिडन रहती और एज ए MD पैथोलॉजिस्ट, एज अ मोटिवेशनल स्पीकर आपसे यहाँ पर बात नहीं कर रही होती। तो बात सारी फेथ की होती है ऑलमाइटी पर, बात सारी हौसले की होती है, एक करेज की होती है, एक जज्बे की होती है कि हमें अपनी कंट्री को कुछ रिटर्न देना है। बिकॉज कंट्री ने हमारे लिए बहुत कुछ किया है, हम बहुत लकी है, हम ब्लेस्ड है कि हम इंडिया में पैदा हुए हैं, हम इंडियन है। बहुत प्राउड है मुझे इस बात का। और बहुत प्राउडली मैं ये भी कहना चाहती हूँ कि मेरा मकसद ये है कि मैं अपने कंट्री के लोगों की हेल्प करूं, मैं उन्हें मोटिवेट करूं और हम सब लोग एक साथ मिलकर अपनी कंट्री को आगे लाएं दुनिया में। तो एक छोटा सा जो शेर है मैं आप सबको कहना चाहूंगी, सिर्फ कहने से नहीं बनता, कुछ करना पड़ता है। सिर्फ कहने से नहीं बनता, कुछ करना पड़ता है। भुलाकर सारी मुश्किलों को अपनी जिद पर अड़ना पड़ता है। इतना आसान नहीं है सपनों का हकीकत हो जाना, इतना आसान नहीं है सपनों का हकीकत हो जाना। कभी दुनिया से तो कभी खुद से लड़ना पड़ता है। Thank you so much everyone for listening me this humble state. Thank you so much. Maya ma'am, thanks a lot for inviting me here.
Thank you, Roshan madam.
We are very proud because I am from the same institute. We are really proud of you. Yeah.
Roshan ma'am, it's really hats off to you, your strength and your perseverance. शायद आपके बोलने के बाद हम बोल ही नहीं सकते कुछ, फिर भी once again a very thank you from the whole team of doctors and all the listeners who are there, who were there with us today to listen to you. Madam, please accept our e-bouquet from every one of us.
Thank you ma'am, it's mean a lot to me.
Thanks a lot madam. Maya madam, पुढे घेऊ मी?
Yes.
Now I request Dr. Manisha Katikar madam to say a few words.
Today's motivational speaker, Dr. Roshan Sheikh, Dr. Swati Gadgi, respected Vice President ISA National, Dr. Anjali Bhure, Secretary Dr. Naveen Malhotra sir, and team SAPC. Heartiest congratulations to you. And I must say, Dr. Roshan, after listening to you, such an incredible journey. And I'm highly impressed, and I must tell you that along with me, my mother-in-law, who is 84-year-old, and my daughter, who is pursuing her medicine and is in final MBBS, is also sitting next to me, listening to you. and so many of family members of Maharashtra State ISA and others who have joined this program with their family members.
Hello.
It was really nice listening to you and listening to Swati madam. Thank you, Maya madam, for such an excellent program. Thank you very much.
Can speak. Thank you, madam. Sorry, there's a problem from my side, but let's go ahead. Now I invite. Yes, madam.
Seema, Markande sir wanted to speak something. I think he has raised the hand.
Okay,
So-
yes, ma'am. He is most welcome to speak. I don't know where is he. Dr. Markande
Okay.
sir. I don't think he is here, madam.
Go ahead.
ठीक है, it's okay. Yeah. You can continue, no problem.
Please. Yeah, ma'am, there's an electricity problem at my side. Can you please continue? Or should I just, because my connection is also unstable.
Okay. Yeah, I request Honorary Secretary ISA National Dr. Naveen Malhotra sir to say a few words and give good wishes to Dr. Roshan. She is really hardworking, so courageous. I'm really inspired, Roshan. Whenever I listen to you, I really get inspired each and every moment, and I find new vision to my in my path.
Thanks
Sir,
a lot, ma'am.
can you-
Thank you.
Yeah, over to Naveen Malhotra sir.
Thank
Sir,
you, Dr.
please.
Maya Valero. Yes, I'll begin first with Dr. Roshan only. And I like to say, मंजिलें उन्हीं को मिलती हैं जिनके सपनों में जान होती है. मंजिलें उन्हीं को मिलती हैं जिनके सपनों में जान होती है. पंखों से कुछ नहीं होता, हौसलों से उड़ान होती है. So this is for Madam, and which you have shown over the years since 2011. Down to MBBS, to your MD, and it's very nice listening to you. But dear Dr. Maya Valero, President SAPC, Dr. Seema Suryavanshi, very dear Dr. Sumit Lad, Dr. Manisha Katekar, President ISA Maharashtra, Dr. Avinash, Secretary, and very, very dear Dr. Anjali Bhure, Vice President ISA National. Greetings to ISA Maharashtra and ISA SAPC for arranging back-to-back programs on International Women's Day. And yes, I've seen whole of the video, which was released by ISA Maharashtra day before yesterday. Excellent. Salutes to the concept. Salutes to the beautiful and wonderful women anesthesiologists. And yes, today, Dr. Maya Valero, to be honest, it was a very, very long day for me clinically also. And since 4 a.m., I am back to back clinical and academic and webinar work going on. But I enjoyed every bit of it. And I listened to Dr. Swati also. Ma'am, you have really said about family chemistry. I could understand some bit, some which was in Marathi. I was trying to gather, but I can say that when we talk of family, I want to say कि दुनिया के लिए आप एक व्यक्ति हैं, दुनिया के लिए आप एक व्यक्ति हैं, लेकिन वो परिवार ही है जिसके लिए आप पूरी दुनिया हैं. So that is the importance of family and family members. So both the speakers were exceptional and excellent, and I convey my good wishes. And I'm sorry I've joined a bit late because of some connectivity issues. And asked me, "आप Women's Day के ऊपर आप क्या कर रहे हैं?" So this is the program of Women's Day. What are you doing there? So, and you should give time to me. Because don't worry, I'm doing a justifiable job as a national secretary to be there with my branch at SAPC. Heartiest congratulations to all of you, and thank you for inviting me here. Once again, I convey my warm regards to the women anesthesiologists, the role model across the country, whether it is at city level, state level, and national level. Few hours ago, there was a talk going on about leadership roles by the women anesthesiologists. And I am a firm believer that all the women anesthesiologists are playing leadership roles at every stage, whether it is at home, whether it is at the department, whether it is at association level, city, state, or national. Leadership positions, whenever they want, they can take it, because they have their own priorities towards their family, commitments, more commitments than males. I've got no reluctance in confessing that they are more dedicated, more sincere, more disciplined, better human beings. Salutes to all the women anesthesiologists. Thank you for inviting me here. Thank you.
Thank you.
Thank you, sir. Thank you so
Thank you,
much.
sir.
Thank you, Malhotra sir, for your kind words of appreciation and motivating us once again. We are very, very grateful to you, sir. You are with us today, sparing your valuable time. Now I invite Dr. Anjali Bhure, madam, who has also graced this webinar, to express her feelings regarding it.
Good evening, all. I'm going to take 2 minutes. So, Maya, as you promised me, 2 minutes. So these 2 minutes are mine. So for Dr. Swati Gadge on achieving family harmony, I think she has very nicely advised us to strive to be bright, enfolding our family members with compassion, positive approach we should have. We should respect each other. If not being together, at least we should be accessible, we should be good listeners, and some chemical reactions should be slow. That is what has really impressed me. Sometimes we can say that we also can err. And your funda on 100 by 100 was a very good concept. As we expect from our children to have 100 and 100, they also expect us to be 100% correct. Then those who say I'll do it and who are willing to take a challenge, even if they are alone, they are true winners. The determination, the commitment to take action yourself is the force that leads to victory. May your faith be the cornerstone of your life, helping you to weather storms. Brave, bold, and beautiful. You are a shining star, Dr. Roshan. Thank you very much. And I think Earth is happy when women smile. So thank you once again.
Thank you. Ma'am, you have really summed up the whole webinar so beautifully. The talks of both our speaker, it's really wonderful. Thank you so much, madam. Maya, madam, can we conclude the webinar, or are there any questions, or someone wants to?
Yeah, somebody wants to speak about our two esteemed speakers. They can have a words and give them some good wishes also. No problem.
माया, मी 1 मिनिट बोलू?
Yes, madam. Yes, yes. Yeah.
खूपच सुंदर प्रोग्राम झाला. दोन्ही स्पीकर्स खूपच छान बोलले. आपल्या पहिल्या स्पीकर स्वाती गाडगीळ ह्यांच्याबद्दल मला सांगायचं की ती बोलली तर खूपच छान, पण आज तिच्या स्टेटसवर तिने अँटी स्पिटिंग वरचा एक व्हिडिओ टाकलेला आहे. अतिशय सुंदर आहे तो. खाली जो ह्याच्यामध्ये आपण अंडरब्रिजच्या खाली जो रस्ता असतो त्या ठिकाणी त्यांची जी अँटी स्पीड कंपॅन आहे ते सगळेजण मुलं चित्र रंगवताना वेगळी वेगळी दाखवलेली आहेत आणि त्याचा व्हिडिओ खूप सुंदर काढलेला आहे. तर कोणी जे स्टेटस असेल ते बघा. खूप सुंदर आहे स्वाती तो व्हिडिओ. खरंच खूप आवडला. आणि ते कंपॅन जे करतेस तो की बाबा थुंकायचं नाही, हा प्रचार खरं आपल्या भारत देशामध्ये खूप महत्वाचा आहे. त्याच्यामुळे बरेच संसर्गजन्य रोग नाही होणार. आणि दुसरी मोटिवेशनल स्पीकर रोशन म्हणेल की मी एवढंच म्हणेल की मंजिल मिले ना मिले ये तो मोहब्बत, ये तो कुदरत की बात है, मगर कोशिश भी ना करे ये तो कोई बात नहीं है. असं ते रोशन शेखनी अपनी कोशिश से आपने तो दुनिया का कायदा ही बदल दिया है पूरे हिंदुस्तान का हाईकोर्ट में जाके. सो आपको मुबारक हो और धन्यवाद कि आपकी इतनी मोटिवेशनल ये जर्नी है कि कोई भी सुनेगा तो वो आपका ये जो पढ़ा कि बाबा भगवान उतना ही देता है अपने झोले में जितने हम लोग सहन सकते हैं संकट. That sentence I really liked and we should go for it. Thank you, Roshan.
Yeah. Dr. Roshan has undergone multiple surgeries. I think she was admitted for 3-4 months. Then she had some problem in her spine also. She had to undergo for surgery for that some problem. And later on, she has struggled so much. And my God, she has a motto that she wants to establish her pathology laboratory and she wants to give free treatment to her patients. That is so great, Roshan. I'm really amazed to see your courage. Wonderful, wonderful.
Thank you,
Whatever
ma'am.
help
Thank
you
you.
need, we are definitely there. We doctors, we can help you out in establishing your pathology laboratory, or maybe whatever guidance you want. We are always there to support you as a elder sister, elder brother, or maybe friends.
Thank you, ma'am.
Thank you. Yeah, we can conclude the webinar today then.
Okay, madam. To conclude, and at the end, I would like to thank both of our today's speaker, Dr. Swati Gadgir madam and Dr. Roshan madam, from the depth of my heart. Thank you, madam. I express my sincere thanks on behalf of the team SAPC to Dr. Anjali Bhure madam, Dr. Naveen Malhotra sir, Dr. Katikar madam, who took out their precious time and they were with us today. Thank you, Janika Technologies and Maharashtra State Chapter ISA for their technical support as usual. And a big thank you to all the delegates and the listeners for joining the today's events. Hope the talks given by the speaker were motivating, inspiring, and appealing to you all. I hope you all enjoyed today's webinar. Good night to everyone. Thank you, everyone.
Thank you so much.
Thank you so
all
much. It was
delegates.
wonderful session. Thank
Good
you.
night. Excellent
Yes.
program.
Thank
Maya,
you.
Seema, mast
Thank you,
झालं.
ma'am. Thank you.
Excellent program.
Thank you.
Thank you so much.
Varsha
Thanks a
madam,
lot.
you can stop the recording so that we can have just a 5 minutes chat.
Actually, she has gone. I stopped the recording. Yeah, she's gone. Ma'am, I've stopped the recording. You can go. You can have a talk.
Yeah,
Thank
yeah. Malhotra sir and Anjali madam, Manisha madam, SAPC had organized like 3 programs. One program is for our subordinates or maybe maids or maybe staff. So we decided to felicitate these subordinates, the people who support us in day-to-day life. So all SAPC ladies, they have appreciated their maid, hospital staff by giving a small token of love, like some chocolate or maybe some gift, books, anything. So we did that, and around 20-25 girls, we appreciated our subordinates. That was the first program. Then we had a contribution, all boys and girls. We started, like we did some collection, and we are going to donate this to blind school, which is only for girls. So on the occasion of International Women's Day, we're going to give them some medical equipments, which are talking equipments like thermometer. Then it will tell you, because those girls are blind. So they can have a thermometer which will talk. Yeah, your temperature is like this, your saturation is like this. So they're going to buy some equipment. So this is second activity. Third activity is having 2 esteemed speakers with us today. So this was a third activity, like Swati madam and Roshan, Dr. Roshan. And fourth activity is we're going to have a get together where we all girls will interact with each other. So this way we are going to celebrate the week. Thank you so much. Your Manisha madam's inspiration, her motivation is always there with us. Anjali madam is also there and Malhotra sir is also there. So we are blessed to have such a beautiful dignitaries. And we are really thankful to all of you. And our delegates, they are also wonderful. Our executive team, they are very much supportive. Thank you so much.
Thank you. Good to know all the
Chetna is there. I
activities.
think Chetna, you want to say something?
Hello, Chetna.
Hi, I just joined. I'm sorry. I thought it's past
Okay,
10, but
no
still I
problem,
thought
no
I'd
problem.
take a chance and join in. I'm really sorry for joining. Yeah,
Yes,
but
congratulations to all of you for that cultural club video also, which has Maya Balera madam and you and Dr. Manisha and Dr. Anjali Bhure there along with other women anesthesiologists. And
Yeah,
nice to
yeah,
know
we'll do
good
that, sir.
activity going on in SAPC. And I'm very sure Dr. Maya Balera will come up. 2 more activities are lined up. one ISA sponsored West Zone PD Assembly, which she is working very, very hard. And one surprise item, online ISA Art and Literary Club Fest in few months from now as a part of ISA Platinum Jubilee celebrations. So,
yes, sir. Yes, sir. Sure,
I'm
sir.
very sure that it will be a roaring success. Wish you all the best.
Yes, sir.
Good night from my side.
Thank you, sir. Thank you. Thank you.
Thank you, sir.
Yeah, we can.
Good night, everyone.
Good night, madam.
Good night.
Good night. Good night. Yeah. We can end up the meeting. No
Yeah,
problem.
good night.
Good night. Good night, madam. Good night.
Good night. Good night.
Good night, Maya.
Chalo.